realms that oversee them both. It is a platform where diverse perspectives, expertise, and experiences converge to ignite conversations, inspire change, and foster a collective drive toward a healthier future. Throughout this event, we will delve into the pressing issues impacting women's health, discuss strategies for combating maternal mortality, and address the critical matter of human trafficking. Our theme this year, Preventative Maintenance, emphasizes the power of proactive measures in promoting overall well-being. But before we go any further, Dr. Marsh, please give them a little background. Who is Dr. Marsh?
So, I am Dr. Patricia Kelly Marsh. I'm the CEO and co-founder of Ask Me Your MD, where we're real-time answering medical questions from patients all over the world. Yeah. And I also chair the Health Committee for the National Coalition of 100 Black Women, the Metropolitan Atlanta chapter. So that's how I give back to my community.
That is fantastic. So this topic that we're exploring today is going to resonate with you greatly.
Absolutely. That focus on women's health in particular, absolutely.
So when you hear the words preventative maintenance, what does that mean to you specifically?
To me, it means you have to maintain. So that is a continual journey. And you have to learn the things and knowledge that you need to know in order to maintain in the optimal ways.
You know, life has its ebbs and its flows, its highs and its lows, and there are always going to be times when you're going to have to engage in self-care.
That's right.
There is no other way to maintain your optimal level of wellness if you're not engaged in preventative maintenance and self-care. And so today, we have a myriad of topics that are going to allow our listeners to be able to engage in just that.
That's right. It's really, truly going to be a journey that we're taking together. Let's embrace this power of collaboration, empathy, and knowledge exchange. Let us seize this moment to forge new connections, like we're doing right now.
Exactly.
Today.
You know, we just met this morning.
Exactly.
And I think we're sisters already.
Oh,
I feel
yes.
it.
I feel it as well.
There you go.
And we're going to expand our knowledge even and drive meaningful change within our communities. We extend our deepest gratitude to our speakers. Thank you all, our sponsors and partners, those who have generously contributed their time, their resources, and expertise to this year's summit. Your dedication to advancing the cause of women's health is truly inspiring.
To our attendees, we encourage you to actively participate, ask questions, share your insights, and immerse yourselves in the wealth of knowledge that awaits you. This is your summit, and your engagement will shape the transformative impact we strive to achieve. Once again, a warm welcome to the 2023 Georgia Wellness Summit. I am Michelle Nelson, one of your hosts, and I'm a commissioner for the Georgia Commission on Women. Let us embark on this journey together, united in our mission to empower, educate, and elevate the health and wellness of women everywhere. Thank you, and enjoy the summit.
So.
That is the role of genetics in evaluating patients for risks of common conditions. We're going to focus primarily on some common hereditary cancer syndromes and cardiac conditions that we see within our office on a regular basis, and talk a little bit about what our patient interaction is like and how we provide services to those patients. First, I wanted to talk about the interaction between genes and environment, because this comes up all the time with our patients. Patients come in and they want to focus on their family history, who in the family might have a condition of concern. And it's really complicated because while we share genes in common with our relatives, we also share a lot of environmental risk factors too. So you might see a clustering in a family, for example, of heart disease. Is that always purely a genetic condition? Before we get too far into my area of expertise, which is genetics, I want to acknowledge the huge environmental component to those as well. We know that diet, exercise, other environmental pollutions like the air we breathe, the water we drink, the sun we're exposed to, those all impact our health too. And we share those in common with the people that we're related to. So it can be hard to figure out what might be genetic versus what is environmental. And at the same time, the environment always still counts. Even if we're talking about something that is a hereditary condition, the environment still plays a component to that. So basically, my comment right off the bat would be both are important, both interact to prevent or cause a disease. And our genes are not our destiny. We're going to talk about some hereditary risk based on genetic testing that we can perform for patients. But even if a patient is identified to have a hereditary predisposition to a disease, that does not typically guarantee they will develop that condition. There's still other factors like their environment that they interact with that can influence that risk within a patient. So we usually say, like, your genes aren't your destiny. They're just an opportunity for us to determine who might be at higher risk than others. And we can't control the genes we inherit. We all have genes that we inherit from our parents that might have a negative impact on our health. We all have genes that we inherit, hopefully, from our parents that have a positive impact on our health and other aspects of our life. So it's something that we're all in this together to some degree, and genetic testing can just help to predict who might be in higher risk categories for one thing or another. So we all probably have genes that fall somewhere on the spectrum of negative or positive impact for our health as well. Most of us just don't know what they are. As we move into the conversation more about genetics, first talk about what happens as part of our interaction with patients. As I said, I'm a genetic counselor. A genetic counselor has a role that I think is quite interesting in the field of medicine. We are there to walk patients through the process of assessing their risk for a genetic condition, talk about different interventions like genetic testing, what that might mean for them and for their relatives, and then support them through the process of making informed medical decisions based on that information, sharing that information with their relatives. So what I usually tell patients when they come into our office is, my only skill really is talking. We don't have any physical invasive procedures that we provide to patients. Our genetic testing is usually these days like a buccal sample. You don't typically even have to get your blood drawn. We spend a lot of time talking. We take a very detailed medical history of the patient, usually at least 3 generations. So themselves, their parents, their grandparents, and then if possible, the generation below them, if they might have their own children or even grandchildren, to look at patterns in the family to figure out who in the family might have had a condition, how old were they when they had it, how are those people related to each other, so we can map that all out on something we call a pedigree. We also review the patient's medical history. We are looking at their own history of a particular condition, if that's appropriate. We have a pathology report to review, or imaging that we might review, or previous genetic testing that might have occurred in the family, things that can help us add context to our risk assessment. And then we provide a lot of education. We're having conversations similar to what you and I are having today, where we're explaining the role of genetics in a disease like cancer to a patient. We're kind of walking them through the process, or in some cases, cardiovascular health, and we'll talk about those things. And then what do we do with that information? Is there a role for additional screening, or like a procedure that we might offer to lower that patient's risk or try to prevent something from occurring in the first place? And then talk about how they can share this information with their relatives. As we tell patients, you and your relatives share genes and environment in common, as we just discussed. So any kind of genetic testing result we might get for you is something that your siblings, your parents, your children, other relatives might be impacted by that as well. And we might want to talk about how to give them data that they can take to their own healthcare provider to make an informed decision as well. Just because I really like genetics, I want to talk about how we get here, specifically with cancer first, and then go into cardiac genetics as well. And within the cancer world, I want to talk about the fact that all cancer is genetic. All cancer is caused by changes in genes that allow cells to grow and divide at an increased rate, which then can trigger a tumor to develop. And we all inherit, thousands of genes from our parents. But the majority of the time, it's not those genes we inherited from our parents that cause us to develop cancer. It's something else, something in our environment, something as part of the normal course of aging. So this schematic is a very popular one in our world. It's called the two-hit hypothesis. It's to help people to understand that most of the time, these two hits or mutations that occur in our DNA that we have are not something we're born with. They're something that just occurs as part of our routine walking around on this planet. And that's why most cancer occurs in people as they get older, as we're just exposed to more things, as our DNA just isn't quite as precise as it was when we were a young individual. In our patients in our office, what we're trying to determine is, are they born with a copy of one of those genes that's already not working? And these are specifically genes that we target that are called tumor suppressor genes. Their job is to protect you from getting cancer. We all have them. We want them to be working, doing their job. So when we do the genetic testing, we have collated onto our test a collection of genes that we know are responsible for protecting a patient from, whether it be breast cancer, ovarian cancer, prostate cancer, things that we're going to discuss. And then we're looking to see if we can find a change in any of those genes that cause them not to work. That really means that that patient might not have been born with the protection that we would have ideally expected. And that's what puts them at higher risk to develop cancer themselves. They typically are not born with cancer. These are not childhood onset risks that we're talking about. These are still adults that develop cancer in their lifetime. And that's because they have two copies of every gene. They got one from mom and they got one from dad. So in this case, one copy of the gene is not working when they're born, but they still have that extra copy protecting them. It's only through the course of time that they acquire that additional mutation, again, either through some environmental insult like diet, exercise-related factors, smoking, alcohol exposure, just also random errors in cell division that can occur as we get older. That can trigger that second, we call second hit, and then that will develop into a cancer for that individual. So the philosophy behind this is that if you have a hereditary cancer syndrome, you are not born with cancer typically, but you are more predisposed to develop that cancer because you only need one random event to occur in your lifetime in order for that to happen, where the average person needs two. And that cancer tends to occur at a younger age because it's something that it just takes less time in our life for that random event to occur. So, for example, we commonly think about breast cancer. Women, the average age of onset of breast cancer in our country is about 63. If you have a hereditary predisposition, your risk to develop breast cancer is over 50% by the age of 50 with some of these genes. So that risk is pushed down to the younger age. So that's what we're talking about in this situation. So I think that's interesting, but I also really like genetics, so I might be influenced by that. I wanted to, again, use genetic breast cancer as an example of this. We know that the majority of things like breast cancer are sporadic. The majority of people who develop breast cancer don't have a family history. They don't have any other specific risk factors. So in this case, this purple part of our pie graph here, these are cancers that occurred by chance. And the vast majority of women who get breast cancer, and I could extrapolate this pie chart to most every other type of cancer as well, don't have any risk factors we could identify in this case, except for perhaps being a woman. We know that obviously that's an influential risk, although it's not an exclusive risk. and things like ovarian cancer obviously only affect women, prostate only men. Otherwise, there are no other risk factors we identify. I point that out to say this is why all people should be getting screening for the cancers that we think about in the population. It doesn't matter if you have a family history. It doesn't matter if there's any environmental risk factors you may or may not have. A woman who has zero family history of breast cancer, who's a vegan marathon runner, does not have a zero risk. But in our office, we're looking for these folks in this blue bar here. These are folks who have a strong predisposition. They were born with that one hit that we talked about on the previous slide. About 5 to 10% of all breast cancer is hereditary. That's a very similar number for other cancers as well. It's a little higher for a few, but for the most part, about 5 to 10% of all cancer is hereditary, meaning the vast majority of people we offer genetic testing to are going to test negative because they don't have a hereditary predisposition, which is a good thing. But it also means we're back to where we started, and I don't have an explanation for what caused their cancer either. There is this middle of the road category, these folks in this like green area of the bar. This is what we call familial cancer predisposition. This is that concept of shared genes and environment. We might see a cluster of cancer perhaps in like multiple sisters in the same family. Is there something genetic we don't understand? Or is there some shared environmental risk factor that was unique to that siblingship that we don't have a way to quantify? So having a family history still counts, even if you don't have a genetic risk that we can identify with testing. But again, those are both together a smaller portion of the pie than just sporadic cancer by itself. What makes us suspicious that something could be hereditary? These are the things that we tend to look for in our office. These are the clues or the red flags that would trigger us to offer somebody genetic testing related to hereditary cancer. So when we're collecting that pedigree or family history, this is the information we're exploring. First, we're counting how many people in the family had the same type of cancer on the same side of the family. So this is like everybody on mom's side or on dad's side. We're not adding those cumulatively together because in theory, you should not share genes on both your maternal and paternal side. Those should be two separate lineages. So for example, if you have like a maternal grandmother and an aunt and a mom who all had breast cancer, that would be like 3 individuals on that same side of the family. That magic number of 3 is very common for us with hereditary cancer. Or we might see on dad's side, 2 uncles and a grandfather who had colon cancer. That 3 individuals is a red flag for us. We also look for multiple generations that can be affected. This is another clue. So if we see like a parent-child who both have the same type of cancer, that follows the possibility of a gene passing down through the family. So that makes sense to us that maybe there's something hereditary going on there. We also look for certain cancers that can appear together genetically. So our most common examples are like breast and ovarian cancer. They tend to go together genetically. Also things like colon and uterine cancer. With pancreatic cancer, we can see like a pancreatic cancer melanoma syndrome. So we're looking for those common patterns that would make us suspicious. We also look for rare cancers that are more likely to be hereditary. Things that tend to fall into this category are things like triple negative breast cancer. That is a more aggressive type of breast cancer and has shown to be more likely to be a hereditary cause for breast cancer. We also see like ovarian cancer is a rare cancer, much more likely to be hereditary. All of those patients should be offered genetic testing regardless of their family history. Additional examples would be things like male breast cancer or a more aggressive prostate cancer. Those are automatic triggers for referral to our office. But by far, the most concerning thing that we look at is age of onset. And that gets back to that same concept of that tooth hit, where it should, in the average person, should take a while for cancer to develop. Again, it should be something that occurs over the course of a lifetime in 60, 70, 80 years. If you're seeing cancer in people in their 30s, their 40s, even their early 50s, they just haven't walked around on this planet very long. And it makes you wonder if there's some kind of a hereditary predisposition as opposed to something environmental that's triggering that cancer in that individual. This is just an idea of autosomal dominant inheritance to remind you of, this is like high school biology class, of how genes work. So we all have, again, 2 copies of every gene. We get one from mom and one from dad. The vast majority of these hereditary cancer syndromes that we're going to talk about, and also some of the cardiac conditions we're going to talk about, are what we call autosomal dominant conditions, meaning you have one copy of the gene that's working and one copy that's not. And then there's a 50-50 probability which of those you pass on to your children. So in this situation, if we have two parents and the parent on the right is affected, if they have that copy of the gene that's not working, there's a 50-50 probability which of their children they might pass it on to. But it doesn't work perfectly. It's just like gender is a 50-50 probability, right? You could have 4 children. All 4 of them could be girls. All 4 of them could be boys. You could have 2 and 2. Even if you have a mutation, there's a 50-50 probability for each of your children independently to inherit that change. You could have all affected, all unaffected. It's just something that is unique to each of those conceptions. So we keep that in mind. But we tend to see patterns of multiple affected generations. And if you're unaffected, if you didn't inherit that mutation, your children are not at risk because you don't have that mutation to give. So that's helpful in some of these families to understand that concept as well. Why does it matter? What's the big deal here? We think about things like, again, hereditary breast cancer. We know that having a mutation in one of these genes puts you at significantly higher risk for cancer than the general population. So these purple bars are the risks in people who have a gene mutation, like a BRCA gene mutation, which is the most common hereditary cause of breast and ovarian cancer, compared to the general population, which are the folks with these green bars. So as I said, it's a much higher risk by a younger age. And we want to treat these people differently. We don't want to just do a mammogram starting at 40. We want to offer the appropriate intervention based on that level of risk. So if we find these patients, we can better match up their medical management options based on what's going on with them. And let's talk about that. So this is just an example. We have a lot of genes we know associated with hereditary cancer, but I just want to walk through the scenario of what this can mean for somebody's health. In this situation, if we have a woman who comes into our office, we do genetic testing on her. She's identified to have a BRCA gene mutation. She gets put into a different risk category based on the data on the previous slide. We're going to treat her differently. We're going to offer more aggressive options starting at a younger age. So at the minimum, she's going to be offered breast screening starting at 25 years old, which again is considerably younger than the general population. We usually start with a breast MRI at that age because it's really hard to do breast imaging in a very young woman because of dense breast tissue. As she gets older, into her 30s, we're going to add a mammogram to that, also done yearly. Ideally, we tend to alternate them so they have 2 touch points throughout the year. So they're not getting all their screening done in 1 week and then going 12 months in between. So they might get a mammogram in January and a breast MRI in July and then continuing on that cycle so that they have the opportunity to meet with a physician, do a clinical breast exam every 6 months as opposed to every year. And we do offer some screening for ovarian cancer as well. Sometimes this is the other component to BRCA gene mutations, is a breast and ovarian cancer syndrome. But the screening is unfortunately not great and it's not a proven intervention. So we have things like ultrasounds, blood tests, but it's not routinely offered just because it's not good enough for this population. We can take it to the next level. We can offer patients often medications that can reduce their risk for cancer. In this specific scenario of a woman who is a higher risk for breast and ovarian cancer, there are common hormone blocking medications, something like tamoxifen, that we can offer to reduce that risk for breast cancer. They take that medication for at least 5 years. It cuts their risk for breast cancer by about 50%. So that's significant risk reduction in a woman that she might find appealing. There are side effects with every medication, and that part she might not find as appealing. So there are things for her to consider. There are pros and cons, but that is an intervention that should be offered to her. And then the other is the birth control pill, oral contraception. Anything that stops ovulation allows us to have a lower risk for ovarian cancer. And when we are using contraception that has a mechanism to stop ovulation as why it works, then we're going to lower the risk for ovarian cancer for that patient as well. So in this case, a birth control pill or something equivalent, taken at least for 5 years during the childbearing period, can cut the risk for ovarian cancer by 50% as well. So that's a common option for those patients. And then we talk about surgery. Surgery is an option that is much more personal. It's a more invasive process for patients, and in some cases it's more of a recommendation, and others it's more of an option. When it comes to things like ovarian cancer, if a woman through genetic testing is found to have a higher risk for ovarian cancer, we're not messing around with that. That's a cancer where, again, we don't have a proven effective screen. It's unfortunately a much deadlier cancer than that. The symptoms are very vague and unreliable. So in these families, we recommend that they have their ovaries removed. It has a very fancy name called a bilateral salpingo-oophorectomy. With our most aggressive intervention, that surgery is recommended at age 35. So that's a big deal, but it can reduce her risk for ovarian cancer by close to 95%. And have an added benefit of reducing the risk for breast cancer because it's taking a lot of that estrogen out of the system. So in that case, we're kind of pushy. We tell a woman this is what we strongly recommend because we don't have great alternative options. When it comes to breast health, it's a little more nuanced. We know that women who have a higher risk for breast cancer, if it falls into a category that's significant enough, we should offer them breast surgery, something like a bilateral mastectomy. But it's major surgery. It often involves reconstruction at the same time. So that's two major surgeries at once. And more invasive, it's more visually apparent to others that you've undergone this process. It's a much more personal process for patients. So it's often an option, not as much, we're not as pushy with that, but it's still an option. And it reduces the risk for breast cancer by about 90%, which is as much as we're going to get. But it has to be something that the patient is comfortable with. So it's really left up to the patient to decide when it comes to breast management. And even in these most concerning situations, do we want to do screening? Do we want to add a medication on top of that lowers the risk? Or do we consider something about surgery and let the patient decide what's right for them? And I've used these BRCA genes as an example of this conversation because they're the celebrities in our world. They're the genes that account for about half of hereditary breast cancer. But they're not the whole story. There are lots of genes associated with breast and gynecological health. I just list them here just to give you an idea. It is not that straightforward. We have a menu of genes and genetic tests that we're choosing from these days. They're all different. They all have different cancer risks associated with them. And we need to treat people accordingly based on that. So it's our job as genetic counselors to look at a positive test result and say, okay, what exactly are we dealing with here? Which gene is it? What types of cancers are we talking about? How big of a risk are we talking about? So the patient can get the most appropriate intervention based on that. So it's more of a personalized conversation. It's definitely not a one-size-fits-all approach these days. So for hereditary breast cancer, that's a common conversation we have. Those are perhaps the most common referral indications that we see in our office are for patients who have concerns about breast and ovarian cancer risk. There are impacts for men in these families, again, male breast cancer, prostate cancer. There can be some gastrointestinal cancer risks as well. But perhaps the underlooked risk that we see and that we probably should be seeing more of are patients who are at risk for these hereditary gastrointestinal cancer syndromes. They have a soft spot in my heart. I find them to be particularly fascinating because the genetics of them are super complicated in ways that I do not plan to get into with you today because it's way more than you're bargaining for. But these are individuals who have a much higher risk to develop colon cancer and other related cancers. They tend to also develop more polyps than the general population, and those polyps can become cancer faster than in the general population. So we need to address that with offering screening more appropriately. And they can have a higher risk for other gastrointestinal cancers like upper GI cancers or pancreatic cancers. They also can have a higher risk in some of these families for things like gynecological or breast cancer. So again, it's that same concept of which gene are we talking about, what type of cancer risk, and how do we modify that? But it's more focused on gastrointestinal in that case. The most common hereditary colon cancer syndrome is Lynch syndrome. Lynch syndrome probably isn't that much less common than having a BRCA mutation, but it doesn't get nearly as much attention. About 3 to 5% of all colon cancers are caused by Lynch syndrome. It's really a colon and uterine cancer syndrome because it's also associated with a significantly higher risk for uterine cancer. And honestly, this is pretty much a public health initiative because we have really effective screening and management in these families. So it really behooves us to identify individuals who have a hereditary colon cancer syndrome. And it's about the same proportion. If we took all of these hereditary colon cancer syndromes and combined them, about 5 to 10% of all colon cancers are hereditary, which is about the same as with breast cancer. So it's perhaps just as common, affects men and women, but it's something we don't talk about as much for probably lots of different reasons, but it's pretty important in my opinion. Just to give you an idea of what risks we're talking about, this is Lynch syndrome. Individuals who have a mutation, one of these genes, can have upwards of an 80% lifetime risk for colon cancer. That is much more than the general population. Obviously, that's a very big deal. The general population risk is about 5%. It's, again, a uterine or endometrial cancer condition as well. There can be as high as a 60% chance for uterine cancer in women in these families. So we want to be aware of that and offer them the appropriate intervention. And then it's higher risk for upper GI cancers, ovarian cancers, other things that are part of that spectrum as well. What do we do about it? If people have been diagnosed with this condition, we start colon screening much younger than the general population. Again, we typically are looking at, in the average risk patient, starting colon screening at 45 now, which is different than it used to be. If you have Lynch syndrome, we start that screening as early as 20 to 25 years old, so 20 years younger. And they do a colonoscopy every couple of years. They get into their 40s. They continue to have a colonoscopy every year after that. And we do that because we know it works. By doing this screening that aggressively, we are able to reduce the incidence of colon cancer in those individuals by as much as 80%, which is huge. It almost normalizes that risk for them. And then we talk about upper GI screening to screen for small bowel and stomach cancers. And we talk about gynecological screening, which isn't great, and urine screening for some of the less common conditions like bladder cancer in these families. We also talk about surgery. There are some patients who might have a portion or their entire colon removed if they have a change in these genes. And then a big thing is the gynecological surgeries, things like hysterectomy and oophorectomy, the removal of those ovaries again. So it is customizing risk and customizing intervention based on that. But I would say, and this is the data that I try to impart to my patients who have a higher risk for colon cancer, if we do screening as appropriate, that person's, again, likelihood to develop that colon cancer is reduced to almost the same as the general population. And their life expectancy is normalized. It becomes the same as the general population because even if they were to develop something like a colon cancer, it is much more likely to be an early stage colon cancer that we can treat effectively with maybe a minimal surgery as opposed to something much more devastating like a stage 4 diagnosis where we're doing chemotherapy and things just to try to preserve that individual's life. So it is less focused on. It's something people maybe don't talk about their colons as much, but in our world, just as important, if not more important, because we really know these interventions work. And it's almost a shame if anyone develops like a GI cancer at this point when we have the opportunity to intervene and to prevent that. So hereditary cancers are a big part of what we do. They are a passion of ours. It's really preventative medicine. I want to switch gears a little bit and talk about the heart too, because this is an up and coming area for us. It's probably about 10 years behind where we are with hereditary cancer syndromes, but we are starting to see a lot more patients for heart health in our office. And there are some common indications that get them to us. The most common are patients who are diagnosed with a type of cardiomyopathy, which is an issue with their heart muscle, often with their muscle being too thick, which starts to cause weakness and overcompensation. It just exacerbates the issue. These are the more common types of cardiomyopathy, all of them with a possible hereditary component. Honestly, these are virtually always hereditary conditions. It's just a matter of, do we have a test good enough to find it? So we work now very closely within WellStar with our cardiologists. When they have a patient diagnosed with one of these conditions, that becomes an automatic indication to referral to our office to try to explore the underlying cause of their diagnosis. Is there something hereditary going on for them? What does that mean for them? What does that mean for their relatives, which we're going to chat about a little bit more. But this is, something that we were the first in the state of Georgia to offer adult hereditary cardiac genetic testing. We started doing that about 8 years ago. And this has become about 20 to 30% of our patient population at this point, because we're learning more and more about how common some of these conditions are. Just to give you an idea of what we're talking about, patients are often diagnosed with cardiomyopathy if they start to experience cluster of symptoms. And then looking back in their life, they often tell me, oh, like even as a child, I was short of breath more than my friends. I was, not in bad shape, but I couldn't keep up in PE class when I was younger. They have palpitations, they have syncope or fainting. They can have issues with heart rhythms. They might see a cluster of stroke in the family. These things would all make us suspicious. These are incidents that can unfortunately lead to things like heart failure, and it could be that cardiomyopathy was the cause. So our goal is to find people before these symptoms develop. But if they got to this point, if they're with the cardiologist, if they're given this diagnosis, that's where we might come in on the back end and try to understand what led to that diagnosis for this individual. The genetics of the heart are a mess. These are just some of the genes associated with just cardiomyopathy. There are a lot more genes involved. It is a very complicated genetic testing process because there are overlapping features with different conditions. So I would encourage you, if this is a concern within your family, work with a cardiac specialist in genetics, because it's something that is more nuanced, perhaps even than cancer genetics. So we really want to make sure that the patient's in the right hands of somebody who knows how to interpret these genetic testing results. We've gotten to the point where our cardiac genetic testing involves hundreds of genes, and every one of them is a little different and has a different risk and a different symptoms we might be worried about. So it is a very complex discussion for these patients. Why would we want to know? What's the point? In these families, for example, if we know that there's if we know that there's a cardiac condition, the next step is to offer screening to all of their relatives. So if you know you have cardiomyopathy, your cardiologist will say, now all of your children, your siblings should have baseline cardiac screening, and then should perhaps be followed up down the road. It usually involves things like an echo, an ultrasound of the heart. If we know that there's a genetic test and that there's a positive genetic test, that allows us to prove that we've identified the actual cause of your cardiac diagnosis. But now it also lets us figure out who else in the family is at risk, because we have the opportunity to test them too for the same thing. Which of your children, which of your siblings, and perhaps in some scenarios, your parents, other relatives have inherited this gene as well. So we can focus our efforts. Instead of just doing some, casual cardiac screening for everybody, we can say, this subset of people in this family, these are the folks we need to watch more closely. These are the folks we need to screen every year or so. We need to do the echo. We need to do an EKG, monitor the rhythm of their heart, so that they can be considered for things like having a pacemaker put in earlier, or having medication proactively, so they don't get to the point of having those symptoms that we talked about earlier. And then on the contrary, if then your child, for example, tests negative, we don't have to do as much of that screening intervention, because we know that they did not inherit the gene that caused your diagnosis. So we don't have to be as aggressive at how we follow them. So it helps us to differentiate who's at risk and who's not. It gets a little complicated if we do genetic testing on you, the individual who has a heart condition, and it's negative, because it could just be that we don't have a good enough test, because the genetics of the heart are a mess and we don't know everything yet. So we might still talk about some screening for relatives, just to be on the safe side, again, because they still share genes and environment in common with you, and we don't want to miss anything. So the genetic testing helps us to figure out what that screening might look like for relatives as well. I want to spend a little bit of time specifically talking about a condition that is incredibly common, that is genetic, called familial hypercholesterolemia, which is a very fancy way of saying very high cholesterol that runs in families. This is probably one of the most common things that we find of all the genetic testing we do. About 30% of our patients we test who are coming for this condition, we find a mutation in, compared to about 10% of other conditions. So we're doing better with a better test for these families. And this is something that's probably much more common in the population. These are your folks, and I'm sure some of you are these folks who have high cholesterol, and it just doesn't fit. It's not something that seems to be impacted by diet, exercise. Again, you could be eating right, exercising, and you just can't get that cholesterol below the numbers that we're looking at. In this case, again, we're looking at these high cholesterols in the range that you see on your screen. These are folks who probably have some hereditary predisposition to their high cholesterol. And that's a big deal, because we need to treat them differently than other folks with high cholesterol. They need to be monitored more closely. They need to be offered medications more aggressively, because if they are not, they have a significantly higher risk to develop premature heart disease, stroke, heart attacks, all of these things that we want to avoid. So this is another like public health initiative to find these folks who have familial hypercholesterolemia, and genetic testing is one way that we can do that. There, again, it's a better test. We've identified the majority of the genes that are associated with familial hypercholesterolemia. Not all, there's still this portion we haven't found yet, but it's a smaller targeted test of only 4 or 5 genes that seem to be the culprits. And we're even getting to the point now where there are some like gene medication interactions. So if you have a mutation in one of these genes, it might mean a different high cholesterol medication for you, because we understand this works better in you because of the underlying cellular cause of your high cholesterol versus somebody else who might not have a genetic explanation, and the medication might not be the right fit for them. So it's even starting to influence like prescription choices by your cardiologist, which is why they're sending us a lot of their patients to make sure we're offering them the right treatment. So I just want to highlight that as a big deal that we're seeing in the in the hereditary cardiac world. And the other, just before we close, I want to just introduce you to amyloidosis. This is another common condition. We're hearing more about it. A couple commercials on TV for this recently, because there are some therapeutic medications for this. This is people who have a condition that causes their body not to break down something called amyloid, which is like a plaque that we can get, and it can deposit itself in organs of our body, one of the most important being our heart. It can also affect things like our kidneys. Sometimes it can affect our joints. So this is a condition that is sometimes genetic. There's a subset of this that we call the TTR amyloidosis. These are folks who have a mutation specifically in this gene TTR that cause their amyloidosis. There are other like medications that can cause it, other heart conditions that can cause people to develop amyloidosis. But if there's something hereditary going on, that's a bigger deal. They have a much higher risk. There are very specific medications that these patients benefit from, and they have symptoms much earlier and more aggressively than people who don't have a hereditary cause. So this is another area of like public health focus for us, is to identify these folks who have hereditary amyloidosis, and we're seeing a lot of these patients in our office now too. These are the things that make us suspicious. If you have a known relative who has a mutation, if you see slowly progressive neuropathy or like numbness in the nerves, especially in addition to cardiomyopathy in a patient, those are a combination that makes you think about something like amyloidosis. You can see some heart studies that are unusual in these patients. Again, kidney problems that can pop up in these patients. Another common thing is carpal tunnel syndrome in these families, in addition to heart concerns. So we're seeing our cardiologists ask more of these questions to try to identify these patients. We're seeing even some people like an orthopedist might pick this up, or a hand surgeon. So starting to influence other areas of medicine as well. So a much more common indication than we have seen in the past. And that's kind of my tour of the common hereditary interventions where genetic testing can be helpful, mostly in the cancer space and in the cardiac space. I just wanted to end with some common questions that patients ask us, just so that you're aware of them. First, to keep in mind that not all genetic tests are created equal. You can order genetic testing on the internet for some things. I would just say, be a knowledgeable consumer. There are different qualities of genetic tests, or different standards you have to meet if you're doing genetic testing for a medical decision. FDA approved, has to be vetted through a high quality laboratory. If you order some things on the internet, it might be something that is more for like entertainment purposes or ancestry. That's not really giving you the same level of medical knowledge. So just to be aware of that, and to understand that there is typically not a perfect genetic test either. We don't know everything. We don't know everything about genetics. And then just other common things that come up. People talk about like, why would I want to know this information? We usually have more of an empowering conversation with patients. This is information that you could use to make informed medical decisions. So approaching it that way as an additional piece of data that you could have in your toolbox when you're trying to make some of these decisions. People ask like, can I fix my genes? Well, it comes up a lot. We're not there yet, and like maybe 5-10 years in the future, and there's some exciting technology coming down the road. And you might have heard about things called CRISPR, where they're looking at being able to alter people's DNA. There are a lot of ethics involved with that. Things can get a little complicated, but we're not there yet. We can't fix our genes, but we can, going back to the very beginning, perhaps talk about the environment our genes interact with and how we can maximize the potential of our genes. That might be a different way of looking at it. Another common question that people have are, like, is my genetic test covered by my insurance? How much is it? I will say in general, if genetic testing is something that's medically appropriate, if the person like meets criteria for genetic testing, it's usually covered by their insurance. We work with that process all the time. We're doing pre-authorizations and the documentation that patients need for it to be covered by their insurance. It's also much cheaper in general than it used to be. Genetic testing in the self-pay arena for some of these conditions is a few $100s. It's not a few $1,000s, so it's much more attainable for patients. People are worried about privacy. There are lots of concerns like, will this go into my medical chart in some way? Could this have a negative impact on me there? What I would say is you have lots of laws that protect you in that process. There are federal, and then in the state of Georgia, there are more specific laws that protect your privacy. Our department within our health system is one of the only closed departments because of that. It's something that is not readily available to other doctors. We have to kind of open the door for other folks to be able to see specific genetic testing results for their patients because of that. So we are very thoughtful about genetic information and making sure that it's something that is protected to the best of our abilities. But again, you do have legal protection about that as well. And again, it's something that is more cost effective than it used to be. So there's usually not a financial barrier for patients. If there's a medical reason or desire to be able to do genetic testing, it's usually something that we can get done. So I'm passionate about it. I think it's an exciting time in medicine that genetics is just becoming more and more a topic of conversation across the spectrum of medical intervention. There are specialists that we're working with now that never even thought about genetics 10 years ago, and now they're routinely sending us patients because it's valuable information for them to have as part of their patient's care. So who knows where we're going to be at in the future, but I can't wait to see what happens. Thank you for your time today. I hope you found this to be very helpful. Hi, everyone. My name is Kimberly Kingsbone. I'm the director of the WellStar Center for Genetics. Today, I am going to talk to you about a subject that's
on commercial sexual exploitation of children. We're going to talk a little bit about some of the warning signs to look out for, talk about what the CSEC response team in Georgia, what we can do, how we conduct assessments. And then we'll talk a little bit about prevention in terms of signs to look out for, as well as ways that you can get involved to help end human trafficking in Georgia. So without further ado, I will share my screen. So we'll dive right in, and I'll start talking about the issue and start off with providing some definitions about human trafficking and CSEC in particular. Before I dive into those, I do want to start off by just doing a brief activity where we're talking about some common statements, some of them misconceptions, some of them not, that we hear when people hear of human trafficking or commercial sexual exploitation of children. So there's 3 statements on this slide, and I'm going to go through and talk to you a little bit about if they are a myth or a fact and why that is. So the first statement is youth choose to enter the sex trade. This is something that we hear commonly in our field. Oftentimes individuals think that it's the child's own behaviors that lead to their exploitation. And sometimes youth do have behaviors that place them at risk. But there is a well-known survivor with lived experience who made a statement along the lines that in order for there to be a choice, there has to be at least 2 viable alternatives. And some of the things that we're going to talk about and that you'll start to see throughout this presentation is that for many of our youth, even youth that may be commercially sexually exploited without a trafficker or somebody else forcing or coercing them, often there aren't any other alternatives. They are put in situations where they have to meet their own needs. And so therefore, there isn't much of a choice. Furthermore, there has been some data that's come out surrounding youth, specifically female youth, that have experienced homelessness or unstable housing. And what it found is that over 1 in 3 homeless female youth have engaged in commercial sexual activity based on a study that was done in 2018. And of those individuals that engaged in a commercial sexual activity, 75% of them were approached by somebody else saying that they would somehow provide them some type of basic need or money to meet their basic needs if they were to offer sexual acts. And so a lot of the research shows us that time and time again, that even when there is not a trafficker present, you have vulnerable youth placed in vulnerable situations, and that the buyers of these youth are often the ones that are approaching these youth and tying those youth's basic needs to their exploitation. The second statement is children in the commercial sex industry are bad kids. This is also a myth. Oftentimes when we work with youth that have experienced commercial sexual exploitation, one of the things that we know is they have experienced a whole lot of trauma, and that they're often polyvictimization victims, meaning they have experienced several types of trauma. And so what ends up happening at times is that youth end up getting defined by their behaviors. And one of the things that we know about behaviors is that behaviors are a response to an unmet need or an unaddressed trauma. And so youth that are in the commercial sex industry are not bad kids. They may have behaviors that can be at times sometimes hard to navigate. At times there may be concerns that they leave without permission. At times they may get labels like they're defiant or they're aggressive. But every time when we're working with youth and people start using labels and labeling their behaviors, always remember that behaviors are a response to an unmet need and unaddressed trauma. And the last one is kids solicit sex because of a substance abuse disorder. And so this is a tricky one. This is primarily a myth. However, we know that youth that have concerns for substance abuse are at much greater risk for commercial sexual exploitation. If a youth has a substance abuse disorder, that then puts them in a situation where traffickers or other individuals can then tie the only way that the youth is able to obtain those substances is if they engage in commercial sex acts. And so oftentimes substance abuse disorders can create the vulnerability that places them at risk, but it's not necessarily the substances themselves that are causing the exploitation. It's the environment that's created and the situation where a youth has a substance abuse disorder that's not being met, individuals recognizing that, and then tying the youth's access to substances to sexual acts. Additionally, we also know that a lot of traffickers or gangs that are exploiting youth will use substances as part of a means of coercion. So many youth are forced into substance use, and that is an easy way for traffickers to be able to maintain control over youth. And so the nexus between substance abuse among youth and CSEC is certainly high, but the story behind that can be a little bit complicated. So next, we're going to talk about a few definitions and talk about what human trafficking is, and specifically define what CSEC is. So CSEC falls under a large umbrella known as human trafficking. And human trafficking can simply be defined as a crime that involves exploiting a person for labor services or commercial sex. And so then underneath that umbrella, you have labor trafficking and sex trafficking. And labor trafficking, it involves the recruitment, the harboring, transportation, or obtaining of a person for labor or services by force, fraud, or coercion. And so some common fields or some common businesses that you may see labor trafficking occur could be things like the agricultural industry, the construction industry, the nannying industry, even the adult entertainment industry. Even for our youth. And the adult entertainment industry can provide a concern because youth that are being forced or are working in the adult entertainment industry, they're not able to consent. And so in those situations, you almost have this gray area where a youth is not only being labor trafficked, but sex trafficked as well. And so with labor trafficking, when there is elements of force, fraud, or coercion, and somebody is being forced to provide some type of labor or service for individuals, then that is where concerns for labor trafficking come up. So then sex trafficking is defined as a commercial sex act, which is induced by force, fraud, or coercion, or when the person performing the act is under the age of 18. And so keeping that in mind, the definition for CSEC is sexual activity involving a child in exchange for something of value or promise thereof to that child or another person. So in these situations, the child is being treated as a commercial sexual object. I want to go back to the definition of sex trafficking for a minute, though, because in order for law enforcement and other prosecutors to really be able to start diving into sex trafficking cases, you'll notice that it indicates that an element of force, fraud, or coercion must be present, except for when the youth or when the individual is under the age of 18. And so what that's saying is that individuals under the age of 18 cannot engage in sexual acts in exchange for items of value, which means it doesn't matter if the youth is 16 or 17, because here in Georgia, we do know the age of consent is 16. If items of value are being exchanged either to that youth or to another individual, youth are not legally allowed to consent. And this also goes back to that question that I asked a couple of slides ago about whether youth choose to enter the sex trade. In the state of Georgia and nationwide legally, the answer to that is also no. Youth cannot agree to exchange sexual acts for items of value. And what that also means is that the elements of force, fraud, or coercion do not have to be present in order for a youth to be confirmed as CSEC. So anytime there's a concern that a youth is engaged in sexual acts and either that youth or somebody else has received items of value or a promise of items of value for that sexual act, that would be considered commercial sexual exploitation. Next, I'm going to talk a little bit about where and how trafficking occurs. And so there's generally 6 paradigms of CSEC that are recognized as far as different ways that trafficking can occur. And I'm going to go over each of these in this slide. Oftentimes, when we think about the commercial sexual exploitation of children or human trafficking, a lot of people tend to think of it in terms of what gets portrayed on the media. And so a common movie that some of you may be aware of is the movie Taken. And so a lot of times people have this perception that with human trafficking, youth or individuals that are trafficked or abducted, they're held against their will, possibly put in an area that they're not allowed to leave, and that it happens, things that happen when you go overseas or when you go to big cities. However, one of the things that we know working in the trafficking field and being a CSEC response team is that those situations make up a very small portion of the cases that we see. But the most common paradigm of trafficking that most of us are aware of is trafficking facilitated CSEC or trafficker facilitated CSEC. And in this type of trafficking, that's where you have an individual or group of individuals that are using different elements of coercion and manipulation in order to get youth to engage in sexual acts in exchange for most of the time money. And most of the time in these situations, the trafficker control many aspects of that youth's life, including when they eat, when they sleep, their daily schedule. The youth is forced to engage in sexual acts, oftentimes multiple times a day. And at the end of it, the trafficker takes nearly all of that money. Another type of trafficking, and this is the type of trafficking that we're starting to see more and more of throughout the state, is gang-facilitated CSEC. And with gang-facilitated CSEC, that is where a gang is coercing youth to exchange sexual acts, either as a means to bring revenue into the gang or as a means of initiation into the gang. There was actually a study that was done by the Receiving Hope Center, which is a 90-day receiving facility that accepts and houses youth that are confirmed for commercial sexual exploitation. And several years ago, they did a survey with youth that had been admitted to the Receiving Hope Center. It was all solely based on youth report. And one of the questions that they asked youth is whether they had gang associations. And what they found out is that 66% of the youth that had been accepted into the Receiving Hope Center had reported some type of gang association or gang connection. We believe that that number is actually much higher because we know that due to the secrecy that is involved with gangs and the pressure to not discuss what happens in gangs, that there are several youth that often will not disclose gang involvement. So the fact that 66% of youth readily disclosed that they did have gang involvement shows that the nexus between gang involvement and human trafficking is a very strong one. In the middle, you see a picture of a computer, and that is representative of technology-facilitated CSEC. There has been a lot of research that has shown that technology is actually the #1 facilitator of human trafficking worldwide. And so we know that with technology and access to the internet and social media and different apps, that technology can be used as a magnificent tool to help us improve efficiency and get things done. But we also know that when unsupervised and unmonitored, that it can be a very dangerous place. And that is no different for our youth. A significant portion of the youth that we serve and ultimately end up confirming as CSEC, 70 to 80% of them, as an estimate, at least have some type of technology component to their trafficking, whether that is explicit images or videos of the youth are being shared in exchange for items of value, or whether the internet or apps are being used as a means to set up what is often referred to as dates or plays. But technology absolutely is a massive facilitator of human trafficking, not only in the state of Georgia and not only for children, but for adults too, and nationwide as well. Over here on the top right, you'll see a picture of a house, and that is representative of family-facilitated CSEC. And if you were to ask me which type of CSEC are we lagging behind in terms of identification, or where do we have the most room for growth, I would argue that family-facilitated CSEC is that paradigm where we have the most room for growth. And with family-facilitated CSEC, that is where a youth is being coerced or forced to engage in sexual acts, either with a family member in exchange for items of value, or that family member is arranging for other individuals to exchange sexual acts with the child in exchange for either money or other items of value. A couple of things that we know is that the risk factors that are associated with family-facilitated CSEC are often a little bit different compared to other types of CSEC that youth may experience. For instance, these youth can sometimes be younger, while the vast majority of youth that experience family-facilitated CSEC are still between the ages of 14 to 17. Almost 25% of youth are 13 or below. Additionally, some other research that we know about family-facilitated CSEC is we know that some research tells us that about 60 to 66% of the time when a youth is being trafficked by a family member, that during those instances, about 60 to 66% of the time, it is the mother. The additional 30 to 35% is the father or stepfather or an uncle or some other relative. Some other risk factors that are specific to family-facilitated CSEC is we know that these youth are much less likely to have a history of leaving home without permission or running away, and that the youth themselves are much less likely to have a substance abuse concern, but the family member that is exploiting them is much more likely to have a substance abuse concern. On the bottom right, you see a picture of a youth that's holding up a homeless sign, and that's indicative of buyer-perpetrated trafficking. This was also formerly called survival sex. And with buyer-perpetrated trafficking, these are situations often where a youth may be homeless or doesn't have access to basic needs, and they are engaging in sexual acts in order to meet their basic needs. A few slides ago, I talked about the significant concern, especially among female youth and homelessness, and how often they get approached by adults when homeless to engage in sexual acts. And so with these situations, when youth possibly are experiencing poverty or unstable housing, buyer-perpetrated trafficking is certainly a concern for those youth. And then finally, you see a picture of a massage parlor here, and that is indicative of business-facilitated CSEC. And so with business-facilitated CSEC, that is where a business may be involved in trafficking or having individuals under the age of 18 to engage in sexual acts for items of value. Or it could be a situation where traffickers or other individuals are trafficking youth out of their establishment, and the business is turning a blind eye, likely because that is continuing to bring in revenue for them as well. So illicit massage businesses, adult entertainment industries are some places where youth could be trafficked by the business, but you may also see an element of business facilitated CSEC at a hotel where you have a trafficker that is having a youth stay at a hotel, and the hotel is not reporting those concerns and is allowing it to go on as it's continuing to also provide revenue for that hotel as well. So next, I'm going to talk about the impact. We're going to talk about who's at risk and some of the consequences that are associated with commercial sexual exploitation of children. If you were to ask me what is the one risk factor that is most highly correlated with commercial sexual exploitation, it's absolutely a history of childhood sexual abuse. A lot of recent research shows that between 70 and 90% of youth that are confirmed for CSEC have a history of childhood sexual abuse. And this chart, which is actually borrowed from a nonprofit out of New York that serves trafficking victims, highlights why sexual abuse, especially when it is chronic, especially when it goes unreported or unaddressed, or in situations maybe where the family is not supportive or does not believe the youth, can be such a significant risk factor for CSEC. We know that when children are sexually abused, that first and foremost, that youth's boundaries are violated. Their sense of self, their sense of bodily autonomy, their sense of who they are, all gets violated. And so that can lead to guilt and shame, and it can lead to the child viewing themselves as a sexual object. It can absolutely lead to low self-esteem, and it can also lead to youth not understanding the difference between love, sex, and abuse. That could lead to youth running away or leaving home in order to escape the abuse or because of unaddressed trauma, and that could certainly lead to homelessness. And so in those situations, the low self-esteem, the guilt and shame, or even if they're running away and find themselves in a homeless situation, there's automatically a poverty and a need that is developed. There's needs that are not being met, both on a physiological level, but on an emotional level as well. And so that then opens the door where adults can approach them, where off the bat, as soon as an adult has an interaction with that child, there's an unequal power dynamic. When you combine that with the fact that the sex industry is $1 billion industry, you can see how that can easily lead to youth being approached by recruiters, buyers, and traffickers. This next slide highlights some of the additional vulnerabilities that can place youth at risk for commercial sexual exploitation. The first two that I want to start off by discussing, though, are the two boxes here on the far right. The desire for independence and takes boundaries and tests boundaries and takes unhealthy risk. That may sound like most teenagers. And the reason that we have those included is because we want to highlight that simply part of the teenage experience creates a vulnerability for children. The fact that youth want to be independent, the fact that youth want to be on their own and meet their own needs, and the fact that youth, it's normal in that stage to take boundaries, test boundaries, or maybe take risks that we would not otherwise take, can place youth at risk for CSEC victimization. And so with that, that also means that any youth can become a victim of commercial sexual exploitation. Since we became the statewide response in October of 2020, we have had youth of every gender, every sexual orientation, every socioeconomic status from every part of the state, both rural, suburban, and metro, that have been confirmed victims of commercial sexual exploitation. But it's some of these other additional vulnerabilities that can place youth at increased risk for CSEC. A concerning trend that we're seeing more and more in terms of how youth are being recruited into CSEC victimization is we are seeing that traffickers and gangs and other exploiters are increasingly using peer recruitment as a means to recruit new youth into the gang. And part of that is because from a young age, we do a great job of letting children know that they shouldn't talk to strangers and they shouldn't talk to people that they don't know. And so gangs and traffickers have learned that youth are aware of that. But they also know that especially when you start getting into your teenage years, your primary circle of influence is your friends. And so the people that are most apt, the people that youth are most likely to trust are their friends during this time frame. And so it is very common that we see when youth talk about how they became commercially sexually exploited, it often started with another peer recruiting them. And so if you're working with youth and they're identifying that they know individuals or they are friends with individuals that are involved in CSEC or sex work or trafficking, then that certainly is a red flag. We talked about low self-worth and loneliness and how youth and the need to want to fit in and to feel loved and to be loved and to belong can absolutely place youth at risk for commercial sexual exploitation. Youth that come from a family with a history of substance abuse or dependence absolutely is a concern and can continue to place youth at risk, not only because there's a history of family substance abuse place them at risk for trafficking or intrafamilial trafficking. We also know that could create the scenario where a youth may have unstable housing or experience homelessness. Youth that have involvement in the child welfare system often have an extensive history of abuse or neglect or trauma, and they're more likely to have some of these other vulnerabilities. So when you have youth that have a history of involvement in the child welfare system, that can be another condition that can increase a youth's risk for CSEC. Youth that have substance abuse concerns or youth that have developmental or intellectual disabilities are at risk. There's some research out there that suggests that as a whole, there's an under-identification of CSEC among youth that have developmental and intellectual disabilities, but that they are at much higher risk for commercial sexual exploitation. LGBTQIA plus youth are 7 to 9 times more likely to have to exchange sex for a place to stay as compared to their heterosexual youth. And that could be based in whether if the youth is not accepted within their home community, or if they're getting bullied at school, that may lead the youth to either leaving home or seeking out attention from individuals that creates that vulnerability that could be exploited by another individual. And then the last vulnerability that I want to highlight is being a member of a marginalized population. One of the concerning trends that we have seen since we took over the response in 2020 is that youth of color are significantly overrepresented in our data. Over the last 2 years, at least 70% of the youth we served have been youth of color. And we know that when you compare that to the general demographics in the state of Georgia, that does not match. And so that is absolutely a concern that is present not only in the state of Georgia, but nationwide, in that youth of color are overrepresented, not only in terms of the number of referrals that we receive, but also in terms of the number of confirmations that we have as well. So one of the other things when we look at commercial sexual exploitation, and we look at not only what places a youth at risk of being commercially sexually exploited, but additionally, what may create the circumstances in which a youth may return to a trafficking situation, it can usually pretty easily be explained by Maslow's hierarchy of needs. And so one of the things that we frequently find is that youth that have experienced commercial sexual exploitation often don't have these bottom 3 layers met consistently. So they may not have regular routine access to shelter or food or clothing. We know that they may be coming from unsafe situations, or they may come from a background where they're fearful of individuals either in their family or in their neighborhood. They may come from areas where financial security is a concern, or they may have a concern where their health or the health of their family members is not good. And so many of these youth do not have safety within their home community or within their own home. Additionally, love and belongingness. The need to be loved and to love is part of the human experience. The need to have a healthy and secure attachment, to be able to form friendships, to have a healthy attachment to family, is not just something that teenagers need. It's something that every human being needs. And one of the things that we find is that when you talk to youth that have experienced exploitation, many of them, when you ask them, who is somebody you can trust or who is somebody you can go to, many of these youth report that they don't have anyone and that they cannot trust anyone. And so it's these 3 layers that when they're not met consistently, or when they are being met, but there are strings attached, that can place youth at significant risk for exploitation. And this next slide is a quote by a convicted trafficker who said that my job is to make sure she has what she needs. Personal hygiene, get her nails done, take her to buy an outfit, take her out to eat, make her feel wanted, but I keep the money. And so you can see that traffickers understand that many of the youth that they are targeting don't have their basic needs or their primary needs being met on an individual basis. So they will create the lure or the perception that they will meet these needs for them, but at a cost. And so all of these things are getting done. However, there are significant strings attached. They are being commercially sexually exploited in order to get these things met. There was also a quote by an individual that had testified to Congress about 12 years ago. And one of the things that she pointed out is that whenever she interacted with the system, and when I say the system, I'm not just referring to the child welfare system, I'm referring to community systems. I'm referring to all multidisciplinary team partners that may have interactions with a youth, that when she was in foster care, when she was having interactions with law enforcement or medical staff or other individuals, that they too made it feel like, you know, you can only go to this placement if you do X, Y, and Z, or while here, I care about you as so long as I'm getting my paycheck, or I will answer your phone calls as long as it's during my business hours. And so she said that oftentimes she was made to feel, even when she was part of the system where there's a lot of community members involved in trying to help meet her needs, that everything also came at a cost. And so for her, coming from a background of significant trauma, it felt the same. And so I always say that to highlight that whenever we're working with youth that have been commercially sexually exploited, one of the key things that is incumbent upon us to do after their recovery is to make sure that we're putting youth in environments where moving forward, they're able to get their physiological needs met. They're able to get their safety and belonging needs met, their attachment needs met without strings attached. That they're able to get those needs met consistently, because we know that in the background, the trafficker has been telling them that they can't trust anyone, that they can't trust the system, and that if they go into the system, they'll get put in juvenile detention facilities, or that they won't be able to have access to their phone or to talk to anyone, or that they will get put in jail for crimes they committed as part of their exploitation. Next, I want to show a short video that highlights not only some of these vulnerabilities that we talked about, but it also really touches on what we just talked about with Maslow's hierarchy of needs. And so this is a short 2-minute video, and I'm going to stop sharing my screen so that I can share this video.
I'm trying to tell you what I see in myself when I look in the mirror, but all I see is a silhouette because the figure not clear. But I'm confused. I don't know what to say. I don't know who to be. I don't know what to do. All I know is what it feels like to be half dead and abused. If you don't love nobody, then nobody could hurt you. That's why I'm always stuck in places like this, where they always gotta search you. But I wanna love somebody. I want a mama that'll say this is your curfew, and a daddy that's protective enough not to let anybody hurt you. To me, it's a fantasy, but you say I'll meet the perfect family one day. I say okay to make it seem like your words are forever in my head, but it's not. To me, those words are dead and hot. Need some water to cool this fire in my chest. So many times, suicide almost became the answer, but instead, my daddy was put to rest. They say it's not my fault, but to this day, I still think it is. He'll be here in my arms and I'll be in his. No tears, no harm, and I'll still be a kid. Mama walked out on me when I was 2 because drugs was her new daughter. Something deep inside told me she fought, and there was no way she could have fought harder. I heard stories about me crawling to mama's ID, finding white powder, stumbling to the table, drinking Budweiser, and playing with that green leaf I thought was a flower. 13 or 14 years later, I'm locked up, and it's the best thing that's ever happened to me. I might have been through the struggle, but I'm a survivor as well. So when you ask me who I see in the mirror looking back at me, I'm gonna say a girl who survived hell.
So that video is a video that was created by a youth that has lived experience with commercial sexual exploitation. And you notice that in the video, she frequently went back and referenced many of the things that fit into Maslow's hierarchy of needs. She referenced some possible neglect with mom and substance use, and then talking about safety, not feeling safe, talking about some family dynamics with her father not being around, saying that she just wanted to be a kid, that she wanted to have attachment, that she wanted a father who would protect her. And so you can see that many youth that come from backgrounds where their basic needs are not being met, or they don't have secure attachments, or they have a history of trauma, especially relating to family, that can absolutely be a significant risk factor. This next slide also helps explain why, when working with youth that have experienced commercial sexual exploitation, why at times, even after a youth may be recovered from the situation, or when it's been identified that the youth has experienced commercial sexual exploitation, why they may still continue to return to situations or return to individuals that are trafficking them. If any of you have worked with survivors of domestic violence, you may know that there is a similar power and control wheel when we are discussing domestic violence. As a matter of fact, we know that there's a lot of literature out there that shows that even for individuals that have experienced domestic violence, that often it takes 7 times for an individual to leave that abusive situation before they're able to leave permanently. We also know that the process of leaving is one of the most dangerous situations for individuals that have experienced domestic violence. And those things still ring true for youth that have experienced commercial sexual exploitation. And the reason why so many parallels can be drawn is because some of the same tactics that are used by individuals that are domestically violent are some of the same tactics that are used by traffickers or recruiters in order to maintain control over their victims. And so they will use physical abuse. They'll use emotional abuse and intimidation. They'll use privilege, sometimes tying things like, I'll let you sleep on a bed tonight, but you have to make me X amount of money. Using coercion or threats, denying or blaming or minimizing, telling the youth that they're the reason that they're in this situation, or if she just made more money, that this problem would be solved. And so whenever you think about situations and ask yourself why youth may not be willing to come forward or may not be willing to disclose exploitation, or additionally, why a youth may be returning to a dangerous situation, it's often because there's a significant amount of trauma bonding and there's a significant amount of coercion and intimidation that's used in order to try to maintain control over youth. So far, we've talked a lot about commercial sexual exploitation, and we've talked a lot about specific youth vulnerabilities that place youth at risk. We've also touched on some of the interpersonal reasons, such as peer recruitment, trauma bonding, or dysfunctional family dynamics. But we would be incorrect in assuming that the only vulnerabilities that create spaces where commercial sexual exploitation can go on is only on the youth and family level. There's also situations on the community and societal level as well that continue to reinforce and create environments where commercial sexual exploitation becomes a concern and creates environments where people feel motivated to commercially sexually exploit others. So youth that grow up in areas where poverty is a concern, or in areas where there's a lot of community violence or gang presence, or areas where youth experience a lot of discrimination and inequality, absolutely places youth at higher risk. And we see that with the information we provided a few slides ago, showing that members of marginalized communities are overrepresented in our data. And so we know that there's still a lot of staggering and concerning statistics surrounding youth of color and their exposure to violence and their exposure to discrimination and inequality. And so some of these same concerns in the community level explain some of the demographic concerns we have in asking ourselves, why do these concerning trends, why are they present? But this also gives us the answers on what we can do moving forward to try to help change this narrative and to help reduce this trend. We know that focusing on the community, making community safer, investing in, areas where there is a lot of violence or poverty, and being able to provide more resources to those areas can absolutely help reduce the amount of CSEC victimization that may be occurring in those areas. And then on the societal level, when you have things like gender biases or discrimination, there is a common misconception that only girls can be commercially sexually exploited, but we know that's not true. And we know that boys can as well. And so a lot of research shows that we continue to under-identify boys as CSEC victims, and that there's a lot more male CSEC victims out there that are not being identified. We know that limited resources not only prevent us from being able to effectively serve youth that have experienced commercial sexual exploitation, but we know that it can also inhibit our ability to put prevention services in place to hopefully prevent CSEC victimization as well. And then, throughout the state and throughout the country, just continuing to raise awareness about this issue and helping to advocate for more federal and state laws that increase the punishments for traffickers and buyers, and also on the flip side, are not punishing or arresting youth for prostitution-related charges or charges that they may incur as part of their victimization. Next, I'm going to talk a little bit about our response. So the Children's Advocacy Centers of Georgia, one of the core components of our CSEC response team is taking a multidisciplinary team approach when responding to every concern, every CSEC concern that we receive. One of the things that we know is that if we are working with a youth and there are CSEC concerns that are present, there's often multiple different partners and agencies that are involved with that youth. We also know that a lot of times each partner may have a different piece of the puzzle, may have a different piece of information and background on that child. And that when we bring everyone together, being able to get all of that background and to put all the pieces together can not only help us in ensuring that we're making an accurate assessment, it can also ensure that we're not duplicating services and that youth are not falling through the cracks. And so this picture represents where our primary goal is almost to serve as the centerpiece of a wheel, where when we get a concern that a youth has been exploited, making sure that we're bringing all the partners that are commonly involved in these cases to the table, making sure we're bringing DFACS, Department of Juvenile Justice, the schools if possible, law enforcement, the district attorney's office, medical professionals together to make sure that we're coming up with a coordinated plan to make sure that child's getting what they need. One of the other things as part of our response that we prioritize is whenever possible, trying to get youth connected with a forensic interview. We know that when youth are asked multiple different times by multiple different people about the abuse that they experience, that it can re-traumatize the child, and it can also cause the children to shut down. And so by connecting them with a forensic interview, we're not only limiting the amount of times that we're asking youth to tell their story, we're giving them a space where they're being interviewed by somebody who's trained in talking with children in a non-leading and non-judgmental fashion. And we're also providing the space where the information that is being provided in that forensic interview could then be used to either limit or prevent a youth from having to testify in court should charges be pursued against their traffickers. Another component that we often assist in coordinating for youth where there are CSEC concerns is medical services. We know that youth that have been commercially sexually exploited are much more likely to have a history of STIs and unwanted pregnancy. We also know that they're more likely to have been forced or coerced into using drugs. And so it's important that when youth are recovered, that we're getting them connected with timely medical services so that we can screen to hopefully treat any possible STIs, to screen to see whether or not that youth is pregnant so that we can then begin connecting that youth with resources. And also screening to see if that youth has a history of substance abuse or substance use so that we can then help get that youth connected with those needed services to address those concerns. This is a quick note on mandated reporting. If you are a mandated reporter, CSEC is a form of child abuse. And so anytime those concerns come up, you always want to make a referral to the Division of Family and Children Services, and their hotline is listed here. The contact number to our hotline is also listed, 866-END-HTGA. We are option 2. We have a 24/7 hotline, and we stand ready to be able to jump in and assist no matter what time of day or night when there is a concern that a youth has been commercially sexually exploited. And then additionally, if a youth has been exploited, we always want to make a referral to law enforcement so that that case can be investigated and that the individuals that either engaged in buying that youth or exploiting that youth are being held accountable for that. This is some data from 2022. So last year we received 213 hotline calls. We received 574 web referrals, and we served over 800 youth during the year 2022. So wrapping up, we're going to talk about prevention. So we're going to talk about some red flags, some ways that you can help identify CSEC early on and what we can do to prevent it in the future. So this slide lists some of the red flags that you may commonly see with youth that have been commercially sexually exploited. I do want to highlight that this is not an exhaustive list, but these are just some of the most common red flags. And I also, when you think about red flags and the vulnerabilities that we talked about earlier, I want you to think about red flags and vulnerabilities on a continuum. And what I mean by that is that if a child has, 1 or 2 vulnerabilities and they're exhibiting one red flag, that doesn't always necessarily mean that they are engaged in CSEC. It could, but the presence of more vulnerabilities and red flags that you see, the higher likelihood and the more concern that there is that this youth could be possibly being commercially sexually exploited. And so we talked about youth leaving home or chronic runaway, youth that go missing from care, or going absent without permission absolutely places youth at risk. And we know that oftentimes when youth run away, there isn't a solid plan in place. There is not an individual there that can consistently meet their needs. And so that automatically creates a need where the youth has to be able to meet their own needs. And that then creates that scenario where they could be approached by adults that creates that unequal power dynamic. Having distinctive tattoos or youth having tattoos that we know that the parent did not consent to or that they're not willing to explain is absolutely a concern. Times gangs and traffickers will use tattoos or branding as a means to try to show possession or control over a youth. And so anytime a youth has unexplained tattoos, that absolutely is a concern. Youth that are in the commercial sex industry often experience a significant amount of physical abuse as well as sexual abuse. And that physical abuse can not only come at the hands of their trafficker, but it can come at the hands of buyers as well. So if you have a youth that's presenting with a lot of signs of physical abuse, that is absolutely something to look out for. And then youth that are talking about informal job agreements or are discussing debt to an employer or recruiter are absolutely red flags. There shouldn't be a situation in which a youth has debt to an employer or recruiter, or if a youth is talking vaguely about job agreements they have but are not providing a lot of details, both of those can be significant red flags for CSEC. And then risky sexual behavior can be a tricky one. We always say, as part of the CSEC response team, our job is not necessarily to regulate youth sexual behavior. However, if a youth is reporting that they're engaging in sexual acts with a lot of individuals, or especially a lot of adults, that certainly is a concern and can place them at higher risk for CSEC victimization. Youth that have sudden new goods or services absolutely can be an indicator. So if a youth is getting unexplained cell phones, which is a common thing that we see, maybe they're coming back with their hair or nails done, or they're coming back with different items of value. Something else that we've seen a lot is Cash App or Venmo cards. But anytime a youth has sudden new goods or services or access to money that cannot be explained, that certainly would be a red flag. And then finally, isolation from peers or activity, or a sudden change in who the youth is associating with, especially if that is accompanied by some of these other risk factors, that absolutely can be a concern, as well as sudden changes in behavior. We talked before that behaviors are best thought of as a response to an unmet need and unaddressed trauma. And so when you have a youth that is maybe starting to display a lot of behaviors that are not typical for the youth or marks a drastic change from the way the youth previously presented, that can also be a concern as well. Here are some additional red flags with technology. I mentioned earlier that worldwide, technology is the #1 facilitator of trafficking. And so if you're working with youth and they're starting to display some of these signs, it's certainly an indicator that we may need to ask more questions or possibly make a referral in order to assess what may be going on. So if a youth is taking private phone calls or hiding the screen when you come into the room, becoming increasingly sensitive, being vague about who they're talking to, or not talking openly about what they're doing while online. And if they're increasing the amount of time they're spending online, all of those can be concerns that the youth may be either interacting with individuals that are attempting to exploit them, or they may be in an unsafe situation. A brief plug that I want to also provide here is that with technology, we've also seen a significant rise in sextortion cases. And sextortion is a situation in which a youth is being asked to provide explicit images or photos, and then that individual is then turning around and requesting money or other items of value from that youth, or is continuing to request more and more videos and photos and using threats and coercion if they do not comply. There has been a significant concern, and while not every sextortion case is a CSEC case, we know that it has profound impacts, negative impacts on youth mental health, and it is something that we are seeing a rise in. And so some of these red flags that you see here may also be a sign of sextortion, but could also be a sign of CSEC or the presence of some CSEC risk factors. So safety planning. It's important that when we're talking with youth that we make them aware that, you know, there are people that don't always have their best intentions, and helping talk to them about if situations arise, what would they do? And so this gives just some practical examples that if you are working with a youth that is experiencing commercial sexual exploitation, or a youth where you're concerned that they could, you know, they have some risk factors that place them at risk. It gives you some just practical examples of things that you can talk to youth about so that they understand that they have a safe person to go to should somebody be reaching out to them, attempting to coerce or force them to do things that they do not want to do. So prevention and action. So here are some ways that you can get involved and help stop sexual exploitation here in Georgia. So I appreciate each of you participating in this training today because hopefully you learned something and you gain more knowledge and feel more empowered about hopefully serving and getting a youth connected that may have experienced sexual abuse or exploitation, connected them with the services they need. But also talking to a youth is also important, as I talked about on the last slide, making sure that youth understand body safety, that they understand healthy versus unhealthy relationships and consent, and that they understand online safety and they know who those trusted adults are, as well as their own vulnerabilities so that they understand, you know, if there are vulnerabilities present, ways that other individuals may take advantage of that. Other ways that you can get involved is taking action by sharing this with others or sharing this with your local school district, encouraging them to implement a human trafficking prevention curriculum in their school, or having their staff trained in recognizing the signs of commercial sexual exploitation. The schools, I believe, are a critical partner in helping us in this fight because for most of the year, children spend most of their time within the school system. And so many times the schools are well equipped to be able to not only recognize the warning signs, but also can assist in intervention efforts as well. And so with that, that concludes our presentation, and my contact information is listed here on the slide. So should you have any additional questions or if you have any requests for additional trainings, we are more than happy to come out and talk to your team about commercial sexual exploitation and partner with you. So with that, I appreciate your time today. Thank you so much.
That was an amazing presentation. Again, I am Dr. Patricia Kelly Marsh, and I have with me
Dr. Michelle Nelson.
We are blowing it up in here.
Yes,
I think
we are.
calling, seeing all the technical difficulties, but I want to welcome you if you're just now joining us. Welcome to the 2023 Georgia Wellness Summit. We've heard from Dr. Kimberly King-Spahn. She was telling us about that genetic treatment, prevention, and letting us know a little bit about the testing that you can have in order to prevent some of these cancers that are out there and other conditions. And then we just heard from Dr. Kathleen Cleveland. So she shared with us about the commercial sexual exploitation, some of those signs that we can look out for, and do advocacy on behalf of our children, protecting them and letting them know those trusted adults and places to go for further information. How wonderful has it been so far?
You know, Dr. Marsh, I really am inspired. Genetic testing is not something that I had on my radar, but as I was discussing with another commissioner here this morning, I think it's time because, you know, all of us hear of that one auntie or cousin, someone in the family who may have had some type of cancer.
Exactly.
And you really do need to understand your risk.
Yes.
So I really do say to everyone out there, please consider getting the genetic testing. And please also be observant. You know, sex trafficking is not something that we think of a lot.
That's true.
But if we are aware of the signs, there's someone out there that we can save.
That's right.
Okay, so please be mindful of all these different signs and resources that we're seeing here today that can be applied in a variety of settings.
Exactly. And that is all tuned right into our theme this year of preventative maintenance. So keep these things in mind. We have some wonderful other speakers coming up. You want to tell us a little bit about the next speaker?
I sure do. We are so honored today to have with us Dr. Graham. Dr. Barney Graham is an immunologist, virologist, and clinical trials physician with an extensive background in basic and translational research applied to vaccine development. He is an elected member of the American Society of Clinical Investigation, American Association of Physicians, and the National Academy of Sciences, and has been awarded 2 honorary doctorate degrees.
All right, doctor.
Doctor, absolutely. He is the recipient of the Robert M. Chanock Award for Lifetime Contributions to RSV Research, the Albert B. Sabin Gold Medal Award for Contributions to Vaccinology, the Albany Medical Center Prize in Medicine and Biomedical Research, the National Academy of Sciences John J. Carty Award for the Advancement of Science, the Charles Murrow Award for Achievement in Vaccinology and Immunology, and the Maxwell Finland Award for Scientific Achievement from the National Foundation for Infectious Diseases, and the New York Academy of Medicine John Stearns Medal for Distinguished Contributions in Clinical Practice. He was named one of the world's 100 most I didn't say one of the most 1,000.
No.
One of the world's 100
in the world. Okay.
most influential individuals and one of the heroes of the year in 2021 by Time Magazine, and recognized as the Federal Employee of the Year by the Partnership for Public Service. And I am sure that's his short bio.
That's the short bio, yeah.
We are so honored, we are so thrilled to receive remarks from Dr. Graham. And before he even begins, I want to thank him on behalf of the Commission for his tireless service and for his dedication to medicine and to saving lives. We welcome you, Dr. Graham.
Well, thank you. Thank you. It's my pleasure to be here today, and thank you for that generous introduction. And I'm going to talk to you about respiratory syncytial virus today, and the reason why we're going to talk about it is because there's finally something we can do about respiratory syncytial virus. We've known about it since 1956, but there hasn't been really any treatment or vaccine options for RSV since then, but things are changing, and before this next winter season, we'll have some options, and I really hope you can bear with me, because it's not only important for what you do for your own health, but for other people around you, and for the young people in the room, I want you to notice how cool science is, because there's some things that we can do now that couldn't be done when I was a young person, and it's really stunning to me what can be done. So by way of disclosure, I am a vaccine inventor and a monoclonal antibody inventor on several virus diseases, and I'm on advisory boards and consulting for these different pharmaceutical companies. And today, I'm going to talk about respiratory syncytial virus disease, and then a little bit about the virus, which I think you have to know because the science behind the vaccines make the vaccines more understandable, and then talk about the new vaccines that are just recently available. So RSV infects everybody. It infects everyone by the age of 2 or 3 years of age, and it continues to infect us throughout life, maybe every 3 to 10 years. Disease is worse at the extremes of age, either in the very young, under 6 months of age, or the frail elderly. And in children, globally, there's as many as 35 million respiratory tract infections a year and up to 3.5 million hospitalizations and more than 100,000 deaths. Most of those deaths are in low and middle income countries. Severe disease, and this would be in children who have a severe wheezing pneumonia in their first year of life, that's often associated with childhood wheezing and asthma, and that is caused largely by RSV. There have been problems with vaccines in the past, back in the 1960s when they were first tried, and there is one product, a monoclonal antibody, that can be given to children who are born less than 29 weeks gestation. But other than that, we really have only been able to give supportive care for people who are ill with RSV. And I'm going to concentrate on the adults today because that's where some of the new products are going to be available. And the other reason that maybe you want to know about RSV is because in 2021 winter, September, October timeframe, a couple months unusual, we had a really severe RSV outbreak. After the COVID swept through and suppressed RSV the year before, in September 2021, RSV was really in the news, and almost every family knew somebody who had a child sick with RSV. And something most people don't know is that RSV causes a lot of disease in adults, especially the frail elderly. And I'm just showing you some of the information here, but in the United States, there's up to 1 million medical encounters per year in the elderly, up to 160,000 hospitalizations, and up to 10,000, sometimes 30,000 deaths per year from RSV. Many of these deaths are often attributable to influenza, which we're all used to, and I think everybody thought most respiratory disease was caused by influenza until COVID came along. And once COVID came along, I think people realized there's lots of other respiratory viruses that can be a problem, and one of those is RSV. And just comparing RSV to influenza, you can see that the number of medical events and sometimes even the number of deaths is similar to what you see from seasonal influenza on a year-to-year basis. We have systems set up in this country to do surveillance for viruses, and if you're interested in keeping up with what is circulating around your community, you can actually go to this website and see which of the respiratory viruses happen to be going up in your geography. And so this system, which has been enhanced and was in place before the pandemic, gave us real-time data day by day as the pandemic was going on. RSV is usually a wintertime disease in the northern hemisphere. It's more year-round in the tropical zones, and you see, this is a weekly map from the CDC. Week 52 is the week of Christmas. So what you see is that RSV, on a year-to-year basis, each line is a different year, usually comes up in November, December, peaks in January and February, and then goes back down. But in the COVID epidemic, on the red line in 2021, it was suppressed all winter and didn't really come up until May of that next year, and then came early the next season, and again during 2022 came up early. And so more adults were hospitalized with RSV, and it came a couple months earlier than usual. There's 2 major strains of RSV that co-circulate, and we don't have to spend a lot of time on this, but the vaccine development uses strains A and B, so it's relevant to how you think about this. And so these two strains sort of toggle, they co-circulate, but even in different cities, you see a different ratio of a subtype B versus a subtype A is going on. If you look at how often adults are infected with RSVs, I'm showing you here that RSV infection is about 5 or 6 per 100 among adults. And that, if you add up influenza A and B, that's about the same as influenza, if not a little more. So RSV actually causes a little bit more infection and a little bit less hospitalization than influenza. And it gets worse as you get older. And so once you get up to 65 or so, and then especially as you get up into the 70s and then 80s, the frequency of hospitalization for each of those infections goes way up. And it has a racial disparity component, because if you look at the average age of hospitalization of all people, it's closer to 70, but if you look at Native Americans, it's closer to 60, or in Black and Hispanic populations, it's closer to 60. So there is a disparity in how old people are when they have an average, when their average hospitalization time occurs. It's also associated with other disease conditions. So if you have heart disease, especially if you have congestive heart failure, chronic lung disease, diabetes, these kind of things, in addition to being older, you're much more likely to be hospitalized. And if you are hospitalized, about 20% of those people end up in the ICU, and about 5% of those people end up dying. So we do need a way of dealing with and making RSV go away. When people are hospitalized, this is just a sign of independent living. So about 40% of people hospitalized are already in a dependent situation. They're already usually in nursing home settings. But after RSV hospitalization, their level of independence goes down, and it doesn't recover all the way. So when you have a severe RSV infection as an older person, you often have an acceleration of your other disabilities. So what are we going to do about RSV? And these are the target populations and the period of risk of severe disease as you go along through life. Most of the disease severity happens in the 0 to 6 month of age infants, but about half of the hospitalizations are between 6 months and 5 years of age, and then you acquire a new risk when you get older. Now, the virus. This is where I want the young people to really pay attention, because we can see things now and do things now that we didn't really used to be able to do. And we can now see the virus in great detail. This virus is about several million can fit on the head of a pin. But this is what we can see on the virus, and the virus has proteins on the surface that help it infect cells. And it infects cells of our airway, the ciliated cells in our airway that help us clear our lungs. And if that is infected, it damages our airway, and it also damages the air-blood interface in what we call the alveolus in the very lower lung. So RSV directly infects these cells that line the alveoli and that line our airway. And what we know is from this protein, the F protein, there's 3 proteins on the surface, but the F protein is the one we're going to talk about. People have been trying to make a vaccine with the F protein for the last 2 or 3 decades. And they keep trying and trying, usually with the same result. Either whether they get the F protein from virus or make it in the laboratory, they don't boost our protective level of the body very much, and they never have achieved protection to an extent that they could ever be used as a vaccine. And so in our laboratory back in 2012, after a few years of working with some other groups, and at that time, of Health Vaccine Research Center, where we collaborated across multiple disciplines. And at that center, working with a young man, Jason McClellan, we were able to capture the shape of this virus protein. Now, this protein is about 10 million times smaller than my fist. But we can see it in this level of detail at the atomic level, where each carbon and hydrogen and oxygen atom are located in space. So you can see things at that level of detail, even when they're 10 million times smaller than your fist. And we were able to find an antibody that could hold the top of this protein together, and that antibody it was potent at blocking virus infection. That's what that graph shows. And so by capturing this shape of the F protein, we were able to identify a spot on the top of it that was very sensitive to antibody blocking or antibody neutralization or blocking infection from the virus. And when that protein was purified in the past, or even spontaneously on the virus surface, the protein flips into this other position. And when that happens, that surface, the red surface you see there, disappears. It no longer exists. And if the antibody is trying to recognize that spot and it doesn't exist on that form of the protein won't work very well, and that was shown repeatedly. You get the same result, you just boost the activity a little bit. But if you can now go into the protein and make engineering changes and hold the protein together in the right shape, now you can boost that neutralizing antibody activity that blocks virus infection up to a very high level. And just to show you how this works, so you'll know for the future in your biology classes, this is the virus on the bottom, and it has its genome, the part of it that replicates to make new viruses, encased in this protein, and for it to infect the cell, it has to get into the cell. So this protein that's sitting in the virus membrane starts out in one shape, and then it unravels the top, inserts into that target cell or host cell membrane, and pulls that membrane together like a little motor. It works just like a machine. It's called a fusion machine. When that happens, the membranes fuse, you create a fusion pore, and then the virus can get in the cell. That's what starts replication and infection in the new cell. So if you can block that protein from rearranging, then you can pretty much block virus infection. And so we now know where the antibodies can bind on these F proteins, whether it's in the pre-fusion shape or the post-fusion shape. And we also know that the red and orange spots is what we hit with our antibodies to make it a good vaccine. And there's many ways to stabilize the protein and keep it in this right shape. And so GSK has taken this approach and Pfizer's taken this approach, but they're really very similar approaches to make now what we call the pre-fusion form of the F protein. And this work a few years ago, about 10 years ago, was recognized as a breakthrough by Science Magazine. And now, as we get closer to the finish line, actual vaccines that work, it was recognized again as another breakthrough. So this is really different. This is not the same kind of thing we had been able to do before. So it's resulted in a whole new set of products, and I'm not going to talk about all of these. I'm just going to talk about these two. So GSK has a protein based on that molecule that I just showed you. Pfizer has one as well. The GSK only hits subtype A with an adjuvant that makes it a little more strong. Pfizer gives you both subtype A and B, and the GSK product was approved by the FDA on the 3rd of May, just a few weeks ago, and the Pfizer product was approved just a week or so ago on May 31st. So these two vaccines, 60 years of age, are going to be used for this winter season. And just to give you a sense of how they did that, over that 10-year period, some of the work was done in our lab, and then some of the work was then exported to the companies. And so GSK studied it in more than 25,000 people. Pfizer studied it in over 35,000 people, and they studied it all over the world. In the case of GSK, they were in 17 countries, and Pfizer was in 7 countries, but in 240 sites in those 7 countries. So this data is generalizable to everyone. And just focus on these numbers over here. When you think about milder disease, acute respiratory infection is what that stands for. You're getting about 72% reduction in mild disease, 80% infection against more severe disease, and 94% protection against severe disease. So this vaccine, what's called now Arexvy, is giving 94% protection against hospitalization and severe disease in the elderly. So it's something you should really think about, especially in people who are getting up over 70 years of age, or people who are frail and in nursing homes. Pfizer had similar results, showing that they had 96% efficacy against the really severe disease, and 85% against severe disease and 67% against the more moderate disease. It isn't approved yet, but there's also a vaccine for maternal immunization, because you remember babies are at high risk, and so if you can immunize the mother, increase antibody levels up to high levels in the mother, that antibody is transferred to the baby through the placenta, and now the baby will be born with of RSV. And so we now know that you immunize the mother at the end of the second or beginning of the third, achieve upwards of 81, 82%. There's also antibodies that are made. I showed you on that one slide, like the one that was used to hold together the top to solve that turned into a product that could be given directly. So either be able to immunize mothers to protect babies, or give an antibody directly to the baby through 6 months of life. So now we have adult immunization to get rid of that risk period, and maternal immunization or antibody treatment that can be given to mothers or young babies to eliminate this period of risk for severe disease. And now the work is ongoing for children who are 6 to 60 months of age or so. But there's progress there. It's just going to be a few more years before that can be done. So this is a story about informs public health. And so without doing that basic science work and revealing this new site of vulnerability, you don't get to have a vaccine. So it's really a strong testimony for the importance of investing in basic research. We also now know these new technologies, like structure-based vaccine design is real and it can work. We now have these proteins and vectors and mRNA vaccines that are coming along and shown to be effective, maternal vaccination. And what I haven't talked about today, but that same concept of stabilizing that protein that rearranges to get the virus into a cell, that's what was done to solve the coronavirus problem. And when the coronavirus came out and we got sequences for that virus, we were able to rapidly solve that structure and stabilize it. And that was the basis for the vaccine antigens that are in most of the U.S. government-supported vaccines that we're now using. These 2 vaccines for the elderly are now approved available for this winter season. So if you know people who would qualify for this over 60 years of age, who have some of these risk factors or frail elderly, then you should help educate them about the possibility of getting this type of vaccine to help them through that winter. And my new role at Morehouse School of Medicine, where I'm now on the faculty, I'm focused on, I'm a senior advisor for global health equity. I'm focused on trying to move some of these new technologies and research capacities into low and middle income countries so that they can work on their own disease problems and also have surge capacity when we have these pandemic threats. So there's a lot of work to do in that area as well as the biology. So I will stop there, and if you have any questions, I'll take some of those. Yes.
Not a question, but a comment. I have been all my life. That eventually suffer.
Yeah.
And in different forms and hospitalized in ICUs and all that. We've been waiting for this for a long time. So thank you for all this.
Well, you may not have been able to hear that online, but the comment was from a pediatric pulmonology specialist who's been working and seeing sick babies alive for the last many months. Relief to start having something on the way to try to prevent RSV. Agree with you.
So as a pediatrician, with our premature babies, with the it's a vaccine that we give monthly through the season.
Right. We don't know yet. These studies, both of the big studies by these first two, for the second year, probably for the third year, and as they get going, there's going to be a lot of post-marketing stuff. Once it's in millions of people, there'll be a lot more data to show whether it's needed every year, every 3 years, every 5 years. Based on studies, we think it will last more than a year. The question is whether it's easy to remember to give it every second or third year, or whether it's clinically easier to just give it every year. And so some of those practical things come into play as well. So I think it'll last more than a year for RSV because people have been infected all their life repeatedly, and they're so primed. They have strong pre-existing immunity that it's easy to boost that. And the levels you get with this vaccine are supernormal. You never see this kind of level of antibody response from infection itself. And we don't entirely understand that, but these levels are, I would say, 40 to 50 times higher than you would ever see from an infection. So the level of antibody you're getting from the vaccination will last more than a season, we think.
My understanding, at least in the beginning, was RSV does not give us a local or a immunity when we are infected.
Yeah, so the comment, again, from our pediatric pulmonology specialist was that RSV doesn't give you very long-lasting or effective immunity, systemic or mucosal, after infection. And especially at the beginning of life, most babies have to be infected 2 or 3 or 4 times. That's why it's not until 5 years of age that they start having less severe disease. So between 5 years of age and 65 years of age, we still get infected with RSV, but it's usually just an upper, and it sometimes causes otitis or sinus problems, but it's not a severe disease. But it takes multiple infections in babies usually to achieve that level of immunity where it's not so severe. Yeah, agree.
We think down the pipeline, we're going to be combining all these viral COVID or influenza, and
Right.
RSV into one.
So there's a lot of effort right now. There's so many vaccines, and people hate needles so much that there's a lot of work right now to either combine multiple vaccines like we do for tetanus, diphtheria, pertussis. We combine all those, and we combine measles, mumps, rubella, and now varicella so that we can reduce the number of vaccines. So there's efforts to maybe combine the Tdap with RSV in pregnant women, for instance, so that could just be one vaccine. There's also a lot of effort and advances now, some of it from Georgia Tech, on microneedles, where it's just a little microneedle patch that can go on the arm and deliver the vaccine without the needle, and that's just been proven to be effective for measles vaccines, for instance. And I didn't answer your other question, I remember, that you asked earlier, so I'm going to go back to our pediatrician and the new antibodies that are being developed. One is nirsevimab and from AstraZeneca and Sanofi. The other one from Merck is not approved yet, and I can't remember its name. But these two antibodies have been engineered so that they can have long half-life. So these two antibodies, palivizumab was only available for babies, very premature babies, and you have to give it every month during the winter season. These antibodies have actually been proven to be effective even for full-term babies. So this will be available for all babies. One dose at birth will protect through 150 days. So it's that would be another way to do it. And of course, the maternal vaccine is only a single dose as well.
I'm looking forward onto the horizon of other disease processes. And are there any other disease processes or illnesses that you believe require vaccine that we don't currently have, but should probably be the next big thing?
Well, I spend a lot of my time on pandemic preparedness. And so trying to identify the viruses in these 26 viral families that are known to infect humans and figuring out which ones of those we need to be prepared for, if not all of them. And so to me, the next big thing is figuring out how to prepare for the next big thing. And right, and stay ahead of it. There are other things happening, though, because the mRNA technology that everybody's heard about now is being applied to a lot of other diseases and viral diseases, some of which I think will end up working. And some of the new technologies where you can do this protein engineering and give just exactly what you want to do for a vaccination makes the vaccines more targeted, more effective, and also safer because they're simpler. And so there may, we probably could use for things like CMV. CMV, if it's infecting a mother for the first time or even a reinfection of a mother during pregnancy can often cause congenital problems for the baby and birth defects in the baby. And so trying to manage with vaccines, there's some new data that suggests that could be possible. And so things like that, I think, in the future might be addressable by vaccines as well. No, these adults over 60 years, with or without a complicated medical status. So. Okay. Thank you.
Hello, Dr. Marsh. We're having such an amazing day today.
Yes, everything has been going very well. I love this talk about preventative maintenance by getting vaccines.
Absolutely. So I do have a request for Dr. Graham. And this is a very serious request, Dr. Graham. If you are taking requests for the next new age cutting age vaccine, I would like for you to come up with something, an obesity vaccine. I'm looking for something, I'm serious.
There we go. Absolutely.
Something that will remove calories from my food when I eat
Yes,
and keep me slim.
there we go.
We would be
Cajillionaires. Billionaires. Yes.
So when you come up with that, Dr. Graham, don't forget, we need to get our cut, right?
We're going to get our piece of the cut. We will do the research alongside you. Yes.
Absolutely. And so, but we are laughing about that, but I truly believe that there's going to be something that they will be able to come up with that will be able to, I don't know, we can...
In our lab. We're going to create a lab.
In our lab, we're going to create a lab too. Okay.
And we will present our findings alongside Dr. Barney Graham in the next Wellness Summit. How about
I
that?
want to let everyone out there know that he is just smiling ear to ear at us, saying, "Wow, these two were something else." But I bet you we're gonna find that in a couple of years. So thank you so much for a very insightful presentation, and I'm very grateful for the work that you do. A lot of children are going to be saved, and adults as well.
That is right. We have a lot of pregnant women, and with the, the Georgia Commission of Women, our focus on maternal health, definitely women's health, this goes right aligned with the mission. And I'm just so glad to see the advances that you all are making within RSV preventative care there.
The one thing that we do know in our society, that healthy mothers and healthy babies lead to healthy communities, families, communities, a state, a country, globally. If we don't have healthy women and babies, we have no society at all. So this is a very big step in being able to ensure optimal global health, and we are very grateful for your efforts. And the obesity thing coming up. Okay, very good. Want to plug that again? Absolutely. So on our very wonderful action-packed day that we're having here at the Wellness Summit, I am very pleased to introduce the next speaker. I am wanting to introduce a very good friend, Shelly Ann McKenzie. Shelly Ann is a dynamic healthcare leader and community advocate with a proven track record of success. Her combination of nursing expertise, project management skills, and healthcare technology knowledge has enabled her to make a significant impact on the healthcare industry, improving the lives of patients and healthcare providers alike. Her dedication to supporting healthcare professionals, advocating for policy change, and empowering underrepresented groups in nursing make her a visionary and champion for stronger communities and better healthcare partnerships. Welcome to the summit, Dr. Shelly Ann McKenzie.
Hello, everyone. Hello? Okay. All right. Hello. And just walk all the way out. Hello, everyone. Here? Hi, everyone. How are you today? Thank you so much to the Georgia Commission on Women. Thank you. Thank you to the Georgia Commission on Women for giving me this opportunity and this platform to present today. on the utilization of technology in modern rural healthcare. So today I'll be speaking a little bit to all of us. So all of the audience that's watching, we have healthcare providers, we have IT execs, we have members of our community participating today. All right. By show of hands, how many of you remember the Jetsons? We have a few? We have a few. All right, so it's a 1960s American animated sitcom. So Back to the Future, Star Trek, all of these. For those unfamiliar, technology was infused through every single scene. Robotics, video communication, teleporting, and so on. As you look at the screen, I know you see Rosie, that was her name, right? Rosie. They're robot, and they could do anything, swoop up hairstyles and that type of thing on this thing. Who would have thought that all these years later, we would be able to use technology to transform patient care as well as our daily lives? Now stop and take a look at this picture. Today, many of us find ourselves frustrated and stressed out about computers and technology when they work and when they don't work, right? So in rural healthcare, the evolution of technology and different things like the cost of implementing technology, the infrastructure that needs to be in place and all of that often impact the way technology is implemented in rural health spaces. And then we'll speak about some of the challenges and so on in a little bit. All right, so some of the trends in rural healthcare. There are hospital and provider consolidation. So there's key causes of this, could be the technology pressures, we mentioned cost containment, there are reimbursement penalties, as well as government mandates and post-pandemic stability. So the post-pandemic stability, these are only some of the consolidation, these are some of the key causes, but post-pandemic, the goal is to drive sustainability of our communities and provide the resources so that we could provide more access to care, especially in rural healthcare. So there's been a significant number of hospital closures. Almost 140 rural hospital closures since 2010, as well as in the South alone, 44 hospitals in the South have closed. So this causes major health disparities and people not getting access to the care they need in a timely manner. So how do we sustain our rural communities? So of the 10.8 million people in Georgia, about 1.5 million live in rural Georgia. So today I'll spend some time speaking and just touching a little bit on three aspects or three types of technology that we can leverage to provide more care to Georgians in rural healthcare. Telehealth, mobile health or mHealth, and API. So I'll speak to application programming interface a little bit more. But as we make efforts to drive better technology utilization, it is important to briefly mention workforce and technology challenges that must be considered related to these three top technologies. And then we'll go a little bit into human trafficking and women's wellness and how we can leverage technology to help find solutions there as well. Okay. 44% of rural providers don't have the training or staff to participate in value-based programs. So a recent state of the industry study reveals this number. And it may somewhat seem alarming, but like most rural healthcare and hospitals are struggling to overcome staffing shortages, right? Most of us have issues with staffing shortages, and we're trying to find creative ways. Critical access hospitals also face, because of those lack of resources, physical human resources, to do training and education of not only the patients, but they don't even have the resources to train their staff. So many of them that I've come across recently are outsourcing their help desk or outsourcing or actually sharing resources. So there might be one IT guy for 3 hospitals, especially in rural, depending on where that critical access hospital is. one of the things we can do to mitigate some of these workforce challenges is like my nonprofit Help for Healthcare Professionals. What we do is we go out and we recruit and we retain young and aspiring people who want to join the healthcare workforce and excite them about education and what the possibilities of joining the healthcare workforce can look like. So we excite the youth about careers in tech and informatics and so on. It's very unique, but technology touches every aspect of what we do. So we can rally the community and help do what we need to get more bodies, physical bodies, to the bedside to care for our patients and overcome some of these challenges. Any questions so far? Okay. All right, so according to a recent Becker's article I read recently, 59% of providers want an EHR overhaul or optimization of their IT or their EHR performance. They're citing the need for what? Decreased screen time, less clicks, more accessibility to live chat features and ready customer service responses. So those are some of the things that they cited. In rural health, some of the technology challenges and barriers to implementation include connectivity, right? Internet connectivity and broadband coverage, the technical expertise and the cost as mentioned before. So broadband access is another major disparity in underserved communities. So consider those 1.5 million Georgians that we serve. These challenges should actually serve as a motivator as we strive to provide equity and transform care delivery. So over the next 2 years, broadband will increase and be able to cover more areas across the nation and give people the access that they need through technology to care. The state of healthcare in Georgia. This is just a snapshot. This is a snapshot of what's going on in Georgia today. We have some of the worst numbers when it comes on to healthcare. So throughout the day and throughout the summit, you'll hear more about that, but I've just highlighted a few here. The high underinsured rates, shortage of the healthcare professionals, lack of infrastructure and resources, especially in our rural healthcare, which is what we're speaking about today. And rural Georgia has limited access to healthcare facilities and services. And let's be clear, without us working together and collaborating with different businesses and entities and so on, people will actually die. So it is our duty to work together to find these solutions and make our patients have access to the care that they need. All right, so telehealth, mHealth or mobile health, and open APIs up next. So telehealth connects providers to patients. It connects providers to providers and patients to community-based organizations. We can use it to combat health disparities. They're federally funded now, right? And then it's reimbursed by Medicaid. So when we leverage telehealth, we are more closely connected to our patients, their families, and healthcare resources. And we capture additional revenue, actually, for our hospitals and our clinics, for those of you working in rural health spaces. So think of how telehealth has evolved. So about 15 years ago, I did some research and I did a study on the benefits of telehealth to provide education to those suffering from chronic diseases like diabetes and congestive heart failure and asthma. It wasn't about rural health spaces, but it was a novel concept back then. And although my research was inconclusive at that time, there was significant value in leveraging telehealth. So that was 15 years ago. So come full circle, now we're here, and COVID-19 has accelerated the need to leverage technologies. So if you really think about it, COVID-19 was what, 2020? So in 2020, in less than what, a couple of months, we were able to do about 20 years worth of work, right? And who would have thought, but guess what, the technology was already there. Other industries were using it, and healthcare was a little behind, but we were able to catch up. So there were some entities within 30 days, they had certain things upstanding and in place to be able to provide care for patients or people in the community who could not access services because of COVID-19 pandemic. Any questions? All right, so where to start? So if you're working in a facility, and let's say you are working in IT, you need to examine your current ecosystem. What do you have in place? So most of the people working in tech understand, but I also empower lay people, for lack of better terms, to ask questions where you can. You may be in a leadership role and just different roles, but just ask questions to better understand the utilization of technology in the spaces that you're working in. So people, we need to examine our current ecosystem. So what do we have in place? What types of computers we have in place? Who has access to the computers? What type of applications? What type of software is installed on these computers? So is telehealth an easily accessible option within your EHR? Can people just click, it pops up, 1, 2, 3? Because we want to also make sure that as we leverage technology, we're not creating more barriers or it's not a hindrance to usage. So what percentage of your staff or the patients that you serve or your community are using that telehealth to connect to you and the services that you provide? And then, of course, you need to determine the best type of technology. So if you're in a clinic, you would not necessarily use the same type of EHR as if you're an eye doctor, okay? So there's specialty applications that can be used just depending on the type of space you work in. And just decide on the optimal uses. So many don't understand that telehealth can be used for a general provider visit, your primary care physician, for example. But I work for a company right now where we do telespecialty visits, and we see over 10,000 teleneurology patients monthly in acute care spaces, on ships, in military bases, and so on, and across the nation, of course. So, and we see probably about 13,000 or so telebehavioral or telepsychology patients, psychiatric patients monthly. So we can definitely leverage it to get second opinions and have a provider zoom in and be a part of your different healthcare teams and just bolster the structure and help you provide better resources and services that way. Mobile apps, mHealth. So this creates a bridge between appointments. You can collect reports and share actionable data. It supports patient understanding and drives actual patient engagement and increases people's adoption of the technology to obtain education and so on. So it mitigates inaccessibility issues. mHealth applications, many of us, we have a cell phone, right? So about a couple years ago, it was only on the wish list of especially those living in rural. But everyone has a mobile device now, and they could install an app. It's not ideal for something like telehealth, but worst case scenario, your mobile app could be used to do a telehealth visit. So we can maximize on the benefits in rural by leveraging it that way and being able to have patients and families utilize their smartphones to access healthcare. Okay, so if implementing a mobile app or mHealth, conduct an assessment of the patient population you serve. Again, we don't want things to be a barrier, so 3 steps to implementing is you conduct the needs assessment, who's using it, what are they using it for, and do people have access to the phones? Well, they might have access to a phone, but then they don't have access to internet. So there's an issue there, so that's a barrier. So you just have to assess the patient population that you're serving, what they'll use it for. If it's the aging population, do they have grandchildren or someone that actually understands the technology so that they can leverage it in their home? You may be able to teach your patients at the bedside before they get discharged, but then when they go out into the community, will they be able to use it to make that appointment or to follow up and so on? So just engage providers and ask for app recommendations, collaborate and leverage the expertise and the insights from some of your colleagues that may be using applications, various software, how it works for them, and just engage each other in that process. And then offer the technology training, as I mentioned before, to the patients and families, and ensuring you do some type of assessment as you're doing it so that you know what their situation is at home. Because there are various social determinants of health, that can impact how people access technology, or they might not have a computer, and so on. So those are just some things to look at. Open API. So Open API enables and supports the free exchange of health information between health systems, HIEs, which I'll speak about, health information exchanges, EHRs, and patients. It reduces the overall cost to share data and information, and it allows for real-time, up-to-date patient information at the POC, the point of care. So rural providers can use Open API to improve patient care and profitability. Most of us benefit from the use of Open APIs daily. So think of, you might not know what application, program, and interface is, but if you think of it nowadays, when you log into the computer system and you try to get to another website or something, and it says to you, would you like to use your Facebook credentials? Would you like to use your Gmail credentials to access? That's leveraging Open API. So we use it one way in general, but in healthcare, we use it a little bit differently, but the impact is much greater. So the ONC, the Office of the National Coordinator for Health Information Technology, reported that critical access hospitals are behind the curve in providing patients access to their data. So there's significant difference between critical and non-critical access hospitals, where 62% versus about 74% indicate that there's gaps in access to this care. So there's vendor integration, there's local networking. The Regional Health Information Exchange allows, there are different entities that exist that allow for the sharing of data, not only between providers for post-discharge care and so on, but information can be shared, for example, when we report our vaccination data to the state, right? So that crosses through a HIE and things of that nature. So there are different ways, different regions, the computer systems are connected together. So you can have a computer system, if a hospital is in Atlanta, they could connect to a rural hospital, they just kind of share data through an exchange there. Now let's touch a little bit on women's health and maternal care. The Georgia Commission on Women, their 3 pillars are women's wellness, maternal mortality, and human trafficking, as we know. So how can we leverage technology to support that? The state of women's wellness in rural areas here in Georgia, I mentioned previously that we are at the lowest point. There is so much work to do as it relates to maternal mortality. If you think about it, 82 of our 159 counties do not have obstetric services, right? That's according to the American College of Obstetrics and Gynecology. That's disheartening. As a woman of color, I know that women of color are more are suffering the most from this and lack of access to care. Women have to drive 45 to 50 minutes to see a provider. So that's where we could definitely leverage things like telehealth for prenatal and postpartum care, mobile apps for maternal care, and so on, and leverage that to do all the follow-up visits and monitor high-risk patients and so on. Again, Open APIs facilitate the sharing of information to improve the care and the coordination of these services. So combating human trafficking with tech. There are tech-enabled solutions that specifically in this space help with training and awareness, not only of healthcare providers and things to look for and questions and answers and different assessments that can be used with specialty technology. There are some technologies for training and awareness like traffic cam and red light traffic that provide resources and training to healthcare professionals so that they could readily identify human trafficking and so on. And then there are also specialty applications for confidentiality and reporting. So there are various entities and different organizations, as mentioned before, that are finding innovative ways, and not only those organizations, but we too need to be creative and think outside the box for how we can transform patient care delivery. So there are telehealth initiatives. The Georgia Partnership for Telehealth and Emory Telehealth Innovation Network are expanding their services to provide services to underserved and rural communities. There are mobile health clinics, mobile healthcare vans that not only serve the underserved and the rural populations, but they come out to health fairs and clinics and so on, like the ones we do all over Atlanta and in different spaces, to bring the care to the members of our community that are not necessarily patients yet, some are, but it's preventative care, right? So we have health fairs and so on. We bring the care, everything from a dental mobile van, we bring all the services out to the park. And some of our members of our community are not going to the doctor. So if we bring it to them, then we can potentially catch that high blood pressure on a blood pressure screen or route them to their primary care provider and so on, and avoid that stroke, for example. So, and then collaborative data sharing platforms. So just share information. GHIN is a network, the Georgia Health Information Network. I know Dr. Denise Hines, over the span of her career, has spent some significant time. She founded that organization to increase the way and expand how we can share data across providers and different facilities and so on across Georgia to share the information. So we avoid the redundancy and the duplication of doing the same blood tests and things of that nature. But there's still more work to do. So the organizations exist, but together we have to do our part to enter the data, right? So if the data is not entered in the system itself can't share the data. So we have to get better at reporting and doing our assessments and reporting and tracking things in the system and monitoring that for us to be successful. The survival of community healthcare. So today we spoke a little bit about the benefits, the challenges, things to consider related to workforce and telehealth and mHealth and API integration in our daily practice. So it's just a little bit of a lot. We only have some limited time here today to speak about some of those benefits, but consider how utilizing technology can help to drive additional revenue within your organization and expand the access for care for Georgians. I have a few key takeaways here. There are about 9, so just imagine the possibilities of what we can do if we leverage technology to transform care delivery and take care of our patients. So just think about what you have in place again. Refresh the physical look and feel of the technology that you have. Research available funding and alternate payment models to support your implementation and utilization of technology. Evaluate the existing technology. Are things on the cloud? Are things stored in the cloud? Has your organization made the investment to utilize cloud-based technologies, or do you still have server-based? Because when you have a server-based application system, then now you require more people resources to have to take care of those servers and so on. So those are just some things to consider there. If you're in rural, consider the benefits of joining a larger healthcare system or form a rural health clinic. So there are a whole bunch of parameters around a rural health clinic, but then you open yourself up to more federal funding and things like that. Invest for sure in broadband connectivity and invest in the training and education of healthcare professionals and recruit aspiring, those who want to join the healthcare workforce but may not have the resources to do it. So go ahead and tap into your local organizations and so on and drive more people to work in our healthcare ecosystem to keep it going. Be sure to address, again, technology touches on so many aspects, and again, we have limited time here, but security, right? Think about privacy and security issues. Cybersecurity issues are real. Hospitals are being held ransom. They're locking down the EHR until monies are paid. So there's a lot going on out here. So just be considerate of that. And definitely, I'd be remiss if I did not mention advocacy. I'm an advocate at heart, but ensure that you advocate for policymakers to address policies to eliminate barriers. So we want to make sure that healthcare professionals have the right licensing, the right type of licensing to be able to provide the quality care that we can get as Georgians, and just make the investment. Is there anything that I missed? Does anyone in here have anything to add to this list? This is just my top 9. Hi.
Hi, I'm Dr. Vicky. One of my dreams is to reduce the economic burden of respiratory diseases in the state of Georgia to begin with. And I'm working with a company who does remote respiratory
Patient monitoring,
I have to start back again.
Okay, start again.
Right. I'm Dr. Devki. One of my dreams is to get economic burden of chronic respiratory diseases down using respiratory remote patient monitoring. I am Georgia-based, and I always wondered what is our broadband connectivity and how effective would we once I secure the marketplace I need.
Well, it just really depends on the area. So broadband connectivity is something that we're really working on in Georgia. We all need to advocate and go talk to our AT&Ts and Comcast and all of them to make sure that we pass the legislation that allows for broadband to be extended into those rural spaces. So it really just depends on the area that you're in, because let's say you go down to, I don't know, Sonoya County. Sonoya County may actually have good connectivity. So it really just depends on your market area and your target area. So just do some research there, and I'll be happy to speak offline about different ways that remote patient monitoring can help your patients for the things like the asthma and the COPDs and things of that nature. The remote patient monitoring companies, and I can help you talk through some of the vendor selection as well, because there's some remote patient monitoring companies that have invested in doing all that research. So they'd be able to not only pitch to sell you their RPM systems, but they can show you the data and the research that substantiates the studies that they've done in terms of the connectivity, in terms of how to, the security, the privacy, and so on. So we could talk about that a little bit more offline. All right, no problem. And I know my time, I'm at my time. So thank you so much for spending time with me this morning. I'd love to hear your thoughts. So let's connect on LinkedIn, and I'll speak with you a little bit hereafter. Thanks, everyone.
Thank you. Thank you. Shelley Ann McKenzie. So in the line of preventative health, I am so excited for the innovation and technology that is going to take rural health prevention to the next level. And that was such an informative question because it honed in on how we can collaborate in helping others who have a hard time getting access to care.
That is absolutely correct. And you know, one of the things that we're really facing here in Georgia, and I wish Shelly Ann was here. Shelly Ann, can you come back up for a moment? I have a question for you. Come on. You know the answer to it. So Shelly Ann, here in Georgia, one of the things that we discuss a lot is inaccessibility to Wi-Fi and okay, so when we're trying to do things like telehealth in rural areas specifically, and we don't have access for those who were underserved, vulnerable, uninsured, to even have Wi-Fi access in their home to do a telemed visit. We know that in Georgia, many counties don't have a physician, OB, pediatrician, no hospital, way too many counties. What is the prescription? And I know that, you know, here in Georgia, even legislatively, we're always trying to find ways to ensure access so that people can get those telemed visits. It's very important, particularly when you're talking about maternal mortality. There's some women who have to drive 100 miles to find a physician, and this is why maternal mortality is so high. We're one of the worst in the country, if not the worst at this time. Can you speak to that? I don't even know. We've all been trying to look for the prescription. Maybe you've got it today.
Might have a partial prescription. We'll start to write it on the prescription pad. But one of the things the Georgia Department of Health has been able to do is, for example, can you hear me okay? Most communities have a library. So it's a meeting space. So they've set up a computer with Wi-Fi at that space, and with hopes that we bridge the gap until we can pass laws for, broadband and so on across Georgia. So most people could get to their library, just like they get to the supermarket. So then now you have privacy, right? Because you're in a locked room, and then you can do your telehealth visit at the library. So the Georgia, so
I like this partial prescription because in that, utilizing infrastructure that's already in place, that's what I'm hearing, and then being creative and taking what's already existing while we are advocating for our policymakers to expand the ingredient for telehealth, which is technology Wi-Fi. We have to have that access first. So I think that was, what do you think about that?
I have a brainwave coming on. Oh, Lord. When Dr. Nelson gets a brainwave, oh, boy, you know what's coming. Here is something IT related that we could look into. You talked about utilization of already existing infrastructure. What about utilization of already existing social pods? You create something where there's someone living in this catchment area right here that has access, and you say, okay, exactly, use your social network, an app even, where you can tap into an already existing social network that you belong to. And you can then go to that person's home, community center, the library as well. But I don't believe that there's something like that exists. So we've got some work to do. Shelly Ann McKenzie. But this is a way. This is, when you have great conversation like this is what tickles the mind to start thinking of how we can use already existing resources to bring about substantive change.
And the impact is much greater when we work together. We tap into these pre-existing infrastructure and the resources that already exist. Again, when I mentioned in my talk a little bit earlier, we did about 20 years worth of work in months, some places in 30 days, because we just had to stand it up. So the technology was there. Banking uses it, right? The airline industry uses the technology. Well, what about healthcare? If we're not healthy, our communities die out, our families die out. Like, people literally die. Physical death occurs, right? So it's that important that we work together to find the solutions and collaborate and tap into the necessary things and have those conversations and bring awareness to people. People are not even thinking. There's some people that are not even thinking about what we're talking about today because it's just not even on their radar. They're like, oh, well, I don't do human trafficking, so that's out of... No, but you need to still be aware. You're a member of the community. You still need to be aware. So happy y'all are doing this today.
Ms. McKenzie, you are now excused. Thank you so very much. And I just want to say, Dr. Marsh, this is how innovation, creation happens. When you look at the captains of industry and the amazing companies that they have built, it has been just a few good individuals sitting in a garage, sitting here today, who come up with amazing initiatives that you just say, what if we just did this small little thing? It really has great impact on society.
Yes. I think you just set me up to talk about Ask Me Your MD before we introduce our next guest. Because it is utilizing the great cell phone. Everyone has it. Everyone has this access to a phone. Even in rural Georgia, even though we have so many trees to slow us down along making more Wi-Fi accessibility. But we decided, what if we doctors made ourselves available via text messaging and chat and have an exchange of that knowledge and information to go along with the 2023 Georgia Wellness Summit's theme of preventative maintenance.
Dr. Marsh, the one thing that you haven't done today, you haven't told us how we find out more information about Ask MD. Like, it sounds amazing, but where do we get this?
Right, so you can go on your cell phone web browser to askmeyourmd.com. It's that simple.
And there you have it, folks. Innovation at its finest, happening right in front of you in real time today. And we're doing this to let you know that this is how knowledge, informed knowledge, is created. It doesn't take a PhD with a ABC and LM and a P and an XYZ for you to decide that you can create something that changes society. All it takes is a great idea and the willingness to follow your dream to help those around you. So please consider, use all of this phenomenal knowledge that you're getting today that is going to enable you to have those great ideas and initiatives. I want to go ahead now and introduce the next amazing speaker. I want to introduce to you Major Anna Sanchez.
Thank you so much.
But wait, I got to read the thing. Major Anna Sanchez has worked in healthcare for over 37 years. She is a clinical nurse for the 94 Air Medical Staging Squadron and provides her clinical expertise in the Nursing Officer Corps and senior non-commissioned officers. She is officer in charge in her element in the nursing section and is responsible in instructing members of the Comprehensive Medical Readiness Program. She delivers a full spectrum of resources for nursing. She educates the total force airmen that directly influences mental wellness and deployment readiness. I want you to welcome to the summit Major Anna Sanchez.
Thank you so much. I appreciate it, Dr. Nelson. Hello, everyone.
And Dr. Marsh,
Dr. Marsh.
we leave, I just want to say, Major Sanchez, thank you so much for your service.
Oh, thank you. It's an
To
honor
the
to serve.
country, your amazing work. We have seen all that you do be a meteoric rise, which has really served to bring awareness to so many. So I'm so proud of you.
Oh,
and
I'm
you
so
know
proud
that.
to be here. Happy to be here.
Yes,
Thank you
indeed.
so much.
You're welcome.
I appreciate everyone here in the studio and Dr. Nelson, Dr. Marsh, and everyone who has contributed to this summit. It is amazing to be here, and I'm just so happy. So let's get on with it. Today, I am going to be speaking to you about human trafficking. This has been an eye-opener for a lot of us in healthcare, especially in mental health. So let's get on with it. I have no financial disclosures, no conflict of interest. I'm doing this for my heart. So today we are going to be defining what human trafficking is, what the scope of the problem. We need to screen and intervene. As most of you there listening in, you guys are in the healthcare arena. So we'll help learn about health consequences, do trauma-informed care as well, and also intervene and prevent what's going on in human trafficking. So that my objective here is to educate you, and so that you will have awareness and have impact to stop human trafficking. So here we go. I'm not going to read to you what's going on here in this, a lot of wording, but this is the UN definition for human trafficking. As you can see, there's the words recruitment, harboring, transportation of patients or people, really, coercion, abduction, fraud, and deception, right? The Department of Justice says that this is a crime that involves coercing people to do things, labor and other services, to engage in commercial sex acts. And it can be subtle, and it can also be overt. Okay? There's exploitation of the minor for commercial sex acts and in human trafficking. So anyone who is involved in human trafficking, it doesn't matter what race you're in, what color, what creed, what beliefs you have, anyone can be affected. So human trafficking, AKA, also known as slavery, okay? It's a public health emergency. I recently just finished my master's in public health, so this is important. It's a public health emergency. It's the exploitation of another person. Again, I'm going to enforce it that this is a crime. It's illegal. Okay, it occurs worldwide. High-income countries, low-income countries, middle-income countries. It is unreported. Since we're here in the Georgia's Wellness Summit, 4 out of every 100,000 people here in Georgia is being trafficked. That is a huge number, okay? 4 million children are trafficked. Look at the age, 5 to 17 years old. Worldwide, 40 million victims of slavery. There's forced labor, forced marriage. And again, I want to emphasize, okay, you guys are in healthcare. Women and girls are disproportionately affected. Look at the numbers that the Human Trafficking Hotline has received in 2019. A lot. 2,500 to 11,500 calls. They are asking for help, asking for you to help them. Half of the survivors of human trafficking attempt suicide because of the trauma that is affecting them. So we need to intervene, we need to act. A lot of HIV infection, STIs, and we'll talk some more about this. What's the scope of the problem? Big scope. No matter where you are, it is happening. Legal or illegal labor industries, any industries in childcare, can you believe that? Elder care, health care, there's drug trade, massage parlors. I was in Duluth a couple months ago, in Duluth, Georgia, and I thought it was a bakery, but it was not a bakery. I thought I was going to get some bread, but it didn't happen. So I had to get out of there and make sure that people are safe. Kind of call, 911, the traffic hotline. Hotel industry, restaurant industry. Who's in the back? Who is cleaning the rooms? Who's washing the dishes? Right? Agriculture, the farms, the farming industries, manufacturing. Hospitality, again, we've talked about that. Factory workers, there's a lot of chicken farms here in Georgia. Who are they using to work there? Nail and hair salons, for those of us who goes to the salon, not me, but check, see, are they being coerced to work there? Domestic servitude, think about that. And of course, the commercial sex work. Who are the traffickers? No single face. It can be a man, it can be a woman, it can be a foreign national or a national or a citizen here. They can be called the pimps, or it could be a romantic partner. that's trying to coerce someone, right? That's the covert way. Community leaders. Think about that. Family members that are involved in this arena, friends, strangers who are just talking to teenagers in the mall, perhaps, or in the parks, right? How about social media? We've talked about social media here, that it is used for the betterment of our society, but sometimes it's used also in a negative way. So we have to inform our children, our patient population who are not able to advocate for themselves. We've talked about the bus depot, the parks, the malls, so be aware where they are. Detention centers, who are working in these areas. How about the shelters, right? Foster care. Think about those places. So what are the myths and realities of human trafficking? We'd think, oh, they're the ones who are kidnapped and just disappear. But usually it's a gradual process. These perpetrators, they groom you, they manipulate you. Again, it's not overt, right? They just kind of make friends with you. I'll feed you. I'll be your friend. I'll be your partner. I'll give you shelter, right? That grooming process. Older males who prey on girls. That's not really a truth to that. There's some truth to that, but it's not all of it, because anyone can be manipulating somebody else. Okay, again, it's any age, any race, any gender, but they target specific population. Myth that these children or people don't go to school, but a lot of them do go to school. So school counselors, teachers, be aware of these things. Traffickers target victims they do not know. It's a myth, because a lot of the times these are your friends, your family, could be community leaders, could be in healthcare, trying to manipulate you, okay? Because these perpetrators, they target the vulnerable. Only undocumented people are trafficked or forced into labor. It's not true, because anyone can be trafficked regarding, it doesn't matter what status you are. Myth that it's a forced labor that does not occur in legal businesses. Not true, okay? Forced labor, any business settings in our communities can happen. These can happen. So as healthcare providers, as teachers, as counselors, you have a unique ability to find out who these people are, because look at the statistics. 80% of the survivors come to us, come to you, come to our healthcare system seeking help. You can identify them, you can intervene, aid the victim. What is the most important thing that you can do for them? Ask them. Have trauma-informed care, be aware of that, and advocate for them, because they usually are not able to advocate for themselves. Talk to them about confidentiality. If they don't speak English, ask for an interpreter, okay? Have that therapeutic relationship, because they might not open to you right now, but maybe in a month's time, they will open up to you and would be ready to help. Asking is not re-traumatizing. There's an art to ask about these questions. You, as the healthcare provider, is a mandatory reporter, okay? Be aware of that. Be aware of safe harbor laws as well. Who are the vulnerable? Let's look at that. 12 to 17 years old. Those who live in poverty, lack of education. They might not have come from a nice home or a safe home, so now they're in the streets, right? They have low self-esteem, poor family support. They don't have that community support as well. The runaway youth, those who live in foster care, those who've been abused, right? So around the world, Let's look at what's happening around the world, those that are displaced due to earthquakes, floods, conflicts, wars. They are at a high risk to be trafficked as well. Here in the United States, look at the migrant workers. They're very vulnerable. The LGBTQ community, and another vulnerable population. Okay, those who have history of substance use. Think about that, right? They've been put in this position. I had a patient one time who was being given the drugs so that they can sell themselves and the pimp would get the money. So they will keep on giving them the medication or the drug that, and get them hooked to this situation. Those who have been incarcerated or gang involvement, or those who've been in the juvie system. So these are our patient population that most of us work in. Be aware. How do we screen and intervene? Okay, as healthcare providers, we can do physical exams, check for absences from school, see if they have bruises, different ways of how the bruises have appeared in their body. How about all of a sudden they have access to nice clothing or handbags? How did they get that? Was somebody buying it for them in exchange for what, right? How about the language that they use when they communicate to you? Have that awareness. When they come to you, if you're in primary care or in the ED and they have multiple pregnancies, STIs, and abortions, right? I'm not going to politicize what the abortions laws are now, but be aware, okay? Chronic runaway. Are they paranoid? Are they all of a sudden having this change of behavior because you knew them at one point and now they're having these behaviors? They're exhibiting behaviors that high anxiety, depression, they're now cutting themselves, right? Be aware of that. How about their partners? Who are they? Are they involved in romantic partners that are their pimp? Are they being pimped to somebody else? Things like that. Are they disoriented when they come to you? Do they feel confused? Do they have risky behaviors? So again, you got to intervene. How do you intervene when they're in this process right now? Multiple STIs, we've talked about that. How about tattoos? Have you checked them? What does the tattoo say? Are they being branded, right? Be aware of that. Ask them about their safety conditions. Where do they live? Do they have any documentations, or is it being withheld to them, from them? Okay. How about cultural trauma? Think about that. Ask. Again, if they don't speak English, you need to get an interpreter. This is a lot of wordy, but I want you to be aware of it. I'm not going to read it all, but if there's any discrepancies of their behaviors, of their injuries, be aware of it. If they think, or if you think that their answers are very scripted, right? That's a red flag. They know what to answer, but is that really the answer that you think they are going to say? Were they taught? Were they coached? This is the answer that you're going to give. Or they're not wanting to speak with you at that moment, right? If they're with somebody in the room with them, are they deferring to that person? It's like, just keep on looking. I don't know how to answer, and this other person is answering for them. Are they in a controlling relationship? Okay, dominating, right? They're not talking if their partner is there with them. Or are they pleasing this partner that's with them and not answering for themselves? How about their documentation? Where do they live? Are they able to provide that to you? Ask them about their wages. Is it going to somebody else, or are they keeping it? Right? How about their hours of work? Are they working different odd hours or long hours, and they're forced to work, I don't know, 1 a.m. to 5 a.m.? Ask about those things, right? And do they have a way to say, I don't want that work anymore, I can leave? But most of the time when you're being human trafficked or trafficked, you cannot just leave, okay? More on the screen and intervene. Where do you eat or sleep? Ask them, do they ask permission first before they can do these things? Do they feel safe? What are their working conditions? Ask them, are the doors locked, right? Are they able to come in and out freely? Or are they just in a situation where they cannot leave? Ask them if they're being forced to do things that are not something that they want to do, right? They're forced in exchange for food, shelter, okay? Has their documentation, we've talked about this, has that been removed by someone? Have they been denied or threatened their families back home, wherever they are? That if they don't do this job, this is going to happen. Okay? Screen and intervene, very important for you to assess the mental health first aid. What do they need right now at this moment in time? Address and prioritize that because that's what they are needing. Do they have injuries? Do they have fractures? Do they have wounds that needs to be addressed? You got to work as a team with your collaborative psychiatrist, your collaborative doctor, the emergency room team, see what's going on. If they're with somebody, see if that is somebody that they trust or not trust. Is this the trafficker, right, in the room with them? Try and separate them from someone so they can be able to freely answer your questions. Only call the police if needed, because we want safety for yourself as a provider, safety for the patient. Okay, let's talk about communication. What are your do's and don'ts? Encourage them to look at their protective factors. Have they been in a situation where they were able to flee, to move about? You know, are they fast that they can run away? Do they have their documentation with them? Empower them. Strengthen their skills. Educate them. What are their goals? How are they able to move on from this time on, right? Talk to them about exploitation, what those red flags are. A lot of the times there's childhood trauma, and then now they move to this situation. So that they are aware that if they're able to get out from this situation, they won't have it repeated again in the future. Empathy and sympathy, two different things, right? You empathize, you put yourself in their situation, be aware of that. Care for them, okay, that's important. Healthy relationships, boundaries, very important as well. And violence is not acceptable. Okay, there's always a way out. Give them hope. That's who we are as healthcare providers. Okay, don't use crime-specific language. If it's a 13-year-old that's being trafficked, they won't understand that, right? You gotta be at their level. Point out their risk factors. If they're runaway, if they're not having safe housing. Avoid secondary victimization. Don't use textbook language or medical jargon because a 13-year-old, a 12-year-old will not understand that. Okay, let's talk about barriers for disclosure. Fear. Is there retaliation if they speak out? Are they being coerced? Are they being told that I'm going to kill your family if you speak out, if you don't do these things? How about those people who don't have proper documentation here in the United States? Again, I'm not going to politicize this, but do they have fears of being deported, their documentation being removed? Fear of prosecution, okay, that's very real. And have they had experiences with medical health care providers or the police that they don't trust the authorities anymore? There's a lot of shame and guilt, okay? Depression, anxiety, these are things that can happen. And if they're being helpless and hopeless, again, those are barriers. We kind of touched on protective factors, supportive environment. You, as the healthcare provider, need to support that person seeking help. Again, 80% of these patients come to you to seek help. Foster environment of acceptance, non-judgmental, right? I'm here for you. I'm here to listen. Okay, what's the most important thing that I can do for you? You build pride in their community. Okay, if they're in the LGBTQ community, what can they do in that community to empower them? Build relationships, that's important, that empathy, that therapeutic relationship. And who are the people that they can connect? Are there agencies in the local area that they can connect? Talk about healthy relationships, again, boundaries, and internet safety. Okay, let's talk about labor trafficking indicators. We probably, sometimes we in healthcare say, oh, I don't even have time to go to the bathroom. But that's beside the point. This is different, right? Inadequate breaks, abused by employers, not allowed to eat or hydrate because they have to meet a certain quota, no protective gears for those in labor industries or in the sex trafficking community. Do they have protective condoms, things like that, that they can use, right? Are they recruited for a job, but that job is not what they were recruited for, okay? Has there been debt being incurred? Question your patient. What are the effects of labor trafficking? There's a lot, depending on where this person is being trafficked. It can be occupational risks, right? Poor ventilation. Do they work in factories? Do they work in construction, but they don't have proper gears? How about sanitation? Okay, repetitive motion. You work in the factory. This is all you do for 12 hours a day, 15 hours a day, and there's no breaks. How about training? Have they been trained? Okay, exhaustion. Okay, they cannot have any rest anymore. Hypothermia, frostbite, depending on the environment they work in. Accidental injuries, okay? As providers, you gotta ask those things. Are there skin infections, chemical burns, accidental injuries that might have happened because of where they are working? All right, reproductive health. What are the negative impact? We are going to talk about a lot of the sexual trauma here for those who have been sex trafficked. STIs, right? There's a lot of injury. Do they need a SANE exam, sexual assault nurse exam, due to these injuries? Do they have access even to come to the healthcare clinics or healthcare hospitals? Provide them about safer sex education. Provide them where they can get things that they need for the work that they do, right? How about unplanned high-risk pregnancies? What do they do now due to the abortion laws that we're having? Where do they go for help? Forced pregnancies or childbirth even, because of the laws that we have. As a provider, if they're pregnant, where are you going to send them for prenatal care due to this pregnancy, unplanned pregnancy? Is there prevention for HIV transmission? Okay? Physical negative health impacts, we kind of touched on fractures, burns, accidental injuries that might have happened, untreated chronic illness because there's no ventilation or proper ventilation in the areas they work in. Okay, how about TB, communicable diseases? Are they being given drugs that they're having issues now with substance use? Okay, homicide. Think about that, okay? Poor oral health, dislocations, dehydration, malnutrition. We talked about the branding and tattoos as well. Okay? As you know, I'm in mental health. Let's talk about trauma. Have you guys heard of Stockholm Syndrome, where the patient or the victim has bonded to the perpetrator, and that's their safety net? Okay, be aware of that. Affective disorders, depression, anxiety, PTSD, insomnia, panic disorders because of the trauma that they've experienced. Intrusive thoughts, hypervigilance, okay? How about psychosomatic syndromes when they come to you and they say, I have this nausea, I have this headache, vague symptoms that we cannot really have an answer for. Is it because of what they've experiencing that comes out as a physical manifestation of their trauma? Okay, be aware of patients, a population who are trafficked because they're at higher risk for suicide, as I've mentioned earlier, and self-injurious behaviors. Suicide and accidental death, right? Let's talk about that. Accidental death, we never know what happened, but was it suicide? Risky behaviors, be aware of that as well, and educate them, and overdose. I'm going to slightly talk about drug trafficking here. We have heard these in the news that people can ingest bags of drugs and ingested to conceal these drugs to go through customs, right? Body stuffing, and if these things perforate, then that's whole another issue, okay? Here are the symptoms for cocaine, amphetamines. Because of the body packing or the stuffing, this can occur to your patients, so be aware that, it can happen. How about awareness, evaluation, and management? Let's touch on that. As I've said, 80% of these patients come through to your clinics, to your hospitals. Have the awareness. Early recognition is very important. I talked about empathy. Validate them. Validation is key when you're talking to these patients. Okay, psychological first aid, mental health first aid. Ask them, what can they do to have that safety? Okay, can they talk to their perpetrators about these things? Again, their communication skills, right? Empower them. Empower the survivors, be non-judgmental. Again, you as the provider, you are a mandated reporter, so report them. Well, this is it. Conclusion to my PowerPoint on human trafficking. Today, we have talked about our objectives. We have raised awareness on human trafficking. We screen and intervene. Okay, what are the health consequences? The roles and responsibilities for as providers in healthcare, and how we prevent it. Here are my resources: State of Georgia, National Trafficking Hotline, the Homeland Security. These are very important. More resources for you. Questions?
Question I do have.
Yes, ma'am.
Once you've identified an individual and they have the Stockholm Syndrome, and is it just enough to report? You have this person in your space with the perpetrator. Is it just enough to report?
It is a fine line that you have to maneuver as a healthcare provider because, again, the safety of the patient is there, right? That's very important. Are they even ready to divulge that information that I don't feel safe? But what do? Do I live in the street and I'll be trafficked again? And they have this bond with that perpetrator. It's a very fine line. It's an art that you have to maneuver. And again, be there to support the patient because you will never know when that patient will be ready. When you're open, non-judgmental, okay, then they would be more than likely to come back to you again. Does that answer your question? Thank you, thank you. All right.
Another quick question.
Yes, ma'am.
So if you have that individual in your office or in the emergency room with the perpetrator, is there a screening tool, paper that they can fill out that's separate, that the perpetrator may not be able to visualize? Is there a specific screening
That is a
tool?
good question because you're screening for a lot of different things at that time, right? I would try to separate the patient from the perpetrator and try to see what kind of answers they can provide for you. Is this the time to ask questions and be upfront? Do you feel safe in this relationship? Maybe at that time they are because it's better than living in the street, right? So have the patient be the one to lead you and just be open.
But there's no
Ask directly, do you feel safe in this relationship? Do you feel safe in this work environment that you work in? Let them lead the way. Yes, ma'am.
I have a question. For the perpetrators, are there questions that we as physicians can ask that might kind of key a red flag?
That is a good question. I would, if you're able to remove the patient from that perpetrator, I would call security. I would call, the National Human Trafficking Hotline to see how to maneuver that, because my focus is the patient, right? I would defer that to the other police officers or investigations that might prompt, right? Does this person have a rap sheet that's ongoing that you can safely with the patient?
And maybe our pediatricians can help us with this other question as well, but how would you all advise us as physicians to make that separation? What are some of the training tactics that you have provided to do just that?
You can ask the patient to be with you or ask the other person to leave the room while you have some, other screening tools, questions that you can have, right? This is for privacy, this is the patient, I would ask you to leave right now. And that would be a red flag if they say, no, I don't want to leave the person with me right now. Then that would be something that you would kind of think of. Again, they come back to the system because next time it might be another injury, right?
Exactly.
So look at the chart review. See what's going on. Is there a pattern?
Okay.
Right? That pattern is important.
Thank you.
Thank you so much. I appreciate you guys for being here and your questions. All right.
Excellent, excellent. Thank you, Mayor Sanchez. That was super informative. You know, as we are continuing on the 2023 Georgia Wellness Summit, I am just so enlightened and really inspired by all of the knowledge that we're gaining in the ways of looking at maternal mortality, we're looking at human trafficking, and not just in the exploitive sexual, but labor. That was a new way of looking at it that I had not thought about. But those key points and key takeaways absolutely are aligned with the theme of this year of preventative maintenance. Now, it is my pleasure to present our next speaker, Dr. Verada Divgi. Now, she's the first pediatric pulmonologist in the entire state of Georgia, you all. She has over 35 years of experience in medical and legal in medical and legal areas. She's managed and done rehab, several of the modalities and treatments that are used at Children's Healthcare of Atlanta, she actually created, and they are considered standards of care. She's been involved in many different organizations. She was a member of the Paul Harris group, Rotary International member, as well as the leader of the group study exchange in 2001. She was a board member of the Georgia chapter of the Child Domestic Violence group. She's coached over many different employees, young children, women as well, and helped and guided over 5,000 families with challenging medical conditions, as I'm sure she's come in contact with over the years of her career. And I love that she, Dr. Divki, describes herself as a mind gardener, having the ability to master that problem solving in creative and open and explorative ways. It is my pleasure to introduce Dr. Verada Divki.
Hi. Thank you, Dr. Marsh, for that kind introduction. And I'm really enjoying this program.
Excellent. So I'll let our technology team get your presentation pulled up. But as we're getting it pulled up, I did have a question because I was quite shocked and just really proud of you for being the first pediatric pulmonologist in the entire state. What was that process like?
Well, I trained at University of Florida
Okay.
and decided to be in Atlanta area because we needed an international airport.
Ah, yes.
Okay.
I see.
Before I came, all my advisors made me sit down and made me aware that Atlanta is the allergy capital, and I'm going to deal with a lot of allergists.
Oh, yes. So from my knowledge, and maybe you can enlighten us all, but I was told that the state of Georgia has the most species of trees in the United States.
Yeah, but now we are not topping the list. There are other cities that are coming up.
Okay, okay. But that pollen season,
Yeah, it's
it
still
is
terrible.
quite rapid. I suffer from allergies and asthma myself. What are some of the natural ways in which we can prevent asthma exacerbations?
First of all, I would say be aware of your early symptoms. Because patient perception of the symptoms is our really big challenge.
True.
And we see that in children, adolescents, where the denial is too much, and also in elderly people. They don't feel what's going on in the chest, so suddenly they may have trouble breathing when it's gone too far.
Exactly.
Asthma and diabetes are two conditions that I would say where the patient has the ability to manage their condition. Unlike so many others that we don't have any control.
Excellent. That is great advice, really admonishing all of us to know your body and be aware of those early signs and symptoms. Now that we have, look at there, asthma in women. I'm definitely going to stick around for this one, and we will talk soon.
Yeah, I'm going to say that I'm not going to cover asthma per se, but my target is mainly asthma in women. Though I am a pediatric pulmonologist, I see that women are the key backbone of any community. And when we have a team of people just focused on wellness of Georgia women, I chose to speak on this topic. because I feel that together we can promote so much. Agenda is why is asthma in women important? How is it different? Then key target people like pregnant women and elderly women because they are high risk. Then asthma management slightly and the challenges we face. What can we do as a healthcare provider and what can we do as a patient? And then few words on respiratory remote patient monitoring because it's a very important and essential tool for the future. Let's see why asthma is important. Annual figures, 2018 CDC data. We spend about $56 billion of the healthcare budget. 26 million Americans have asthma, 1 in 12 children, 1 in 13 adults. We have a lot of hospitalizations and emergency room visits, about 450,000 hospitalizations, 1.7 million visits. Asthma is the third highest cause of admissions for children under 15. Next one is more important in the sense that, oh, I think I'm going backwards. So, okay, sorry. Every day, at least 10 people are dying of asthma, and African American community is more affected 2 to 3 times than any other ethnic group. CDC data from 2018 points that Georgia spent about $310 million just in asthma, forget about all other chronic respiratory illnesses, among which about 100 million, 101 million were in for the children, and rest 200 million for the adults. Hospitalizations were much higher, like in around over 2,000 for the children and around 3,000 or 3,500 for adults. But the emergency rooms were numerous, about 25,000 in children and 30,000 in adults. And you can see the cost that we pay for that. Need not say why is it important only because of the cost, but the prevalence is also high. About 15 million women, girls and women included, are affected by asthma. About 2 million girls under 18 and 13.5 million over 18. One of the journals had a projection of what the cost would be of the uncontrolled asthma in 20 years. Not surprised to see that the cost can be in billions and hundreds of billions. So what can we do? If we focus on the quality of life of the women and also reduction in our economic burden of asthma, we have work to do. Asthma education becomes important for the healthcare providers to provide to the patients, but the patient also have to take the responsibility of knowing their own asthma. Early symptoms, triggers, their asthma action plans, asthma control test, which is the quality of life, and then knowing your medical team and what to do when you're hurt. All those things pay attention and become important. Again, I'm going to add RRPM, which is remote patient monitoring for the respiratory conditions, coming up mainly due to COVID pandemic. This is a brief reminder for I'll have to point out, of the anatomy. Dr. Graham talked about RSV, and I had made a comment at that time, because the kids under 3 are more vulnerable because their terminal bronchioles, which are the fine tubes here, just before the balloons of the lung are less than 2 millimeters. And in the children, out of the bronchial tree, out of 10 airway pieces, 5 to 6 are under 2 millimeters. So they get into trouble much more. Now, let's come to how asthma is different in women. Lot of factors. You can see it all on the slides. I don't need to go into details, but in the childhood, starting with the childhood, the size of the airways are smaller in the girls and the women compared to the male counterparts. Sex hormone changes, we all know, we go through it. Puberty, pregnancy, menopause, all of them. And also menstrual cycle. There is something called perimenstrual asthma, where there is exacerbation. Environment and work-related are outer external factors, and smoking. Must say that women spend more time in the kitchen, exposed to the gas and other irritants. Some of the hobbies we take on, like painting, jewelry, stained glass, deal with the fumes and all the irritants that we can expose ourselves. We should be mindful about that. Smoking, whether it's active or passive, a very important factor that all of us are cognizant on, how important role it plays in asthma. Comorbidities, this topic will keep on coming. Obesity, diabetes, high blood pressure, osteoporosis, depression, all of them affect outcomes of asthma. Some of the newer ones are the epigenetic and genetics, we know. Let's go more into the hormones. Male hormones, androgen, testosterone, epiandrogen, have a beneficial effect. They help the bronchial muscle to relax and also prevent the proliferation of the cells that would cause narrowing of the tubes, mainly in severe asthma, where there is what we call remodeling of the airways. We are noticing that when the testosterone levels fall after the age of 45, asthma is increased in the males also. In the women, the sex hormones are changing constantly. And puberty and menstrual cycle, they also have showing the exacerbation, worsening of the symptoms, and the frequency of the attacks are more. Low androgen levels that we have take away the beneficial effect on the airway bronchial tree. Now, at puberty, estrogen and progesterone are known to have what we call dysynaptic growth. What I mean by that? The lung parenchyma grows much more than the airway bronchial tree. So there's no correlation on that. Again, the androgen levels are low, so we lose the benefits. When we come to the menstrual cycle, we go through the follicular and the luteal phase. What we are noticing in the luteal phase, we are seeing that the pulmonary function test, symptoms of asthma are worse. So the use of the steroids, visit to the urgent care, emergency room is higher at that time. Pregnancy is a different topic, and I'll go into more details. Menopause also more later, but it's a largest group or most vulnerable group are our elderly women. Some of the important findings seen is that if somebody has hormonal replacement therapy, leaner women have more side effects or more asthma compared to the ladies with higher BMI. That was an interesting finding for me. I learned it when I was preparing for this talk. Now let's talk about asthma in elder women. This is a really very vulnerable group. Specific demographics that have unequal amount of morbidity and mortality. When it comes to the elderly men, women have much more asthma than men, 9.1% compared to 5.7%. Nearly twice as many emergency room visits and hospitalization compared to the male counterparts. But what gets you is the mortality rate, 400%. 400 times any other age group or any other group, either sex. We have the mortality. Now, pre-existing asthma, when gets the hormonal therapy, they handle it well. But postmenopausal females, when they get, when they don't have asthma to begin with, are more at risk to have asthma. And that was an interesting finding. How we respond to corticosteroids, a common group of drugs, is different in women. And elderly women are more affected for the side effects also, given the osteoporosis and all that. When we come again about this, focusing this, what are other features? A lot of times they are the primary caregiver in a household, and they ignore their own health while they are busy taking care of either the kids or the spouses or any other sick person in the family. They also have a lot of comorbidities, obesity, high blood pressure, diabetes. They don't think asthma is that common, or that's not a primary healthcare problem. They are less aware of their asthma symptoms. So when they are doing well, they don't even feel it, and then suddenly have to use more drugs, go to the emergency room, and that's how they utilize it more. These are some of the things. 15 to 35% of the elderly women also show signs of depression. And that again counts to the poor outcomes of asthma control. So this group really becomes more important. When it comes to the obesity, over 60, more than 40% females are obese. And we consider the African American community, the number goes to 54%. And that's something to pay attention. What can we do here? The specialists and the primary care people have to talk to manage all these conditions. Remote respiratory patient monitoring, again, becomes more important. We have to screen this population for depression and anxiety and mental health. And the treatments, we have to be careful. Let's go to asthma in pregnancy. How can I say that? This is a special group. There are some challenges because they give more importance to the baby than taking care of themselves. They may not follow their own medications. But good thing is that among the whole population, 1/3 of them may get better, 1/3 of them stay same, but 1/3 of them do get worse, and 10% require at least one hospitalization. And that's the group we have to watch out. These are some of the, I think it's going, let me go back. %, at least have one emergency room visit and an admission due to asthma. And the exacerbations are more common in the second trimester because the diaphragm is not able to move and there are certain other breathing things affecting their conditions. They're getting more tired. And one of the things is very hurtful is that asthma education is lacking. And so the patients are not participating in the taking their own care and miss out. They are worrying about the medicines that can affect the baby, so they frankly don't take it. And that's how the poor outcome is there. And a lot of them continue to smoke, which is a target, sad, but that is something we do. I have to keep on going on because I think I'm talking, the slides are going faster. One key factor that when we are not able to breathe, our oxygen level falls, what we call hypoxia in the medical terms. And maternal hypoxia quickly results in the fetal hypoxia, affecting the fetal outcomes. And the infants can be affected. So that is something. Complications and adverse outcomes from poor asthma management are plenty. We see it in the moms, we see it in the perinatal time, and also see it in the infants. Well shown here, a lot of conditions like subfertility, spontaneous abortions, acute exacerbations, preeclampsia, gestational diabetes, placental, these are a few conditions that they keep on. When it comes to the babies, we risk the preterm babies, also premature rupture of membranes, and then go for the perinatal mortality. When we come to the fetuses, the babies don't grow well. IUGR, small for gestational age, unless there is gestational diabetes or excessive weight gain where we may have large gestational babies. The neonatal hospitalizations are plenty, and then carrying on of the asthma in the kids is a common thing. Stillbirth and fatalities right at the delivery time is also high in asthmatic women. This is a regular classification for severity of asthma and control, but more pertaining to the pregnancy, but most of the numbers from the healthcare people should be aware of severity as well as symptom control and how we grade them, considering their pulmonary functions also. So what is our management goal in this particular group? We have to contain optimum control of asthma so that we can protect the mom and the fetus, have minimum symptoms, protect our lung functions to the optimal level, and avoid any further risks. Here I put down some outcomes when the asthma is well controlled and when it is poorly controlled. Approximately 25% of pregnant women have at least an emergency room visit and hospitalization during pregnancy. Higher risk is with the exacerbations with the given comorbidities and resulting into maternal and fetal poor outcomes. Well controlled, on the other hand, there is better oxygenation and difficulty, or less challenges in the baby, and all the risks are reduced, whether it is gestational diabetes, IUGR, or small for gestational age babies, preterm labor, premature rupture of membrane, asthma exacerbations, need for systemic steroids, all those conditions are reduced when you manage the asthma better. So it's obvious that we have to do a better job. So as a healthcare providers, what can you do? If an asthmatic woman comes in and is considering pregnancy, that is the starting point that we can start counseling her, tackle all her questions, worries, and guide her into it, and empower her to take care of her own asthma. Let her know the triggers, let her know the early symptoms, let her know the medical treatments and the medical team. And also that she should be going up for the regular checkups and seek attention if she has any exacerbation. Asthma control measures, they should be familiar, like asthma quality of life questionnaire, and exercises to be encouraged. Monitor the fetal growth, mainly in the second and the third trimester, because we want to have the healthy babies. And then follow the asthma guidelines along with the guidelines to manage the comorbidities like diabetes and high blood pressure. Introduce remote respiratory patient monitoring so they know the quality of life on a day-to-day basis than every 3 weeks or every month or whenever the scheduled appointments are, and they can ask for help. If we are a patient with asthma, we have to know our asthma. What are our triggers? What are our medications? Get to know our medical team. Seek urgent attention when there is any change in our symptoms. So awareness of our symptom, early warning signals, whether it's itchy throat, dry cough, chest tightness, whatever we can notice first, be mindful of that and take appropriate action. If you are smoking, smoking cessation becomes a primary must. Also, if you are exposed to secondhand smoke, then also you need to know about avoiding it. Regular checkups, and then self-care regarding the comorbidities. Preventive activities like taking the vaccinations, whether it's influenza, whether it's pneumonia, and given the conditions now, using a mask when you are in the crowded conditions. Tobacco deserves a special mention because active or passive, it causes trouble for the asthmatic. And we pay a lot of cost in health as well as in money. And that is one condition which is totally preventable choice. A lot of things we cannot prevent, but tobacco use we can. So that is where we have to build up our muscle. About 15% of the pregnant women are active smokers, and 30% are exposed to passive smoking. Interesting finding for me here was more females are smoking, there are more smoking pregnant women than non-smoking pregnant women. And that was an interesting finding. In spite of all the education and all the news on tobacco prevention, we still find that, and that was a bothersome finding for me. Know the side effects of the medicine, asthma, and all the other things, and severe risk of exacerbations, urinary tract infection, and preterm birth. Management and challenges. GINA is a global initiative for asthma and has given very clean goals for asthma management. It comes out to achieve and maintain symptom control. Ideally should not have any, though it is only ideal, not practical yet. Prevent asthma episodes or attacks. Maintain pulmonary function as normal as possible. Maintain normal activity, including exercise. And then avoid adverse effects of all asthma medications. Prevent irreversible change. And then prevent the asthma mortality. That is a main thing. This slide, next slide may look busy, but if I simplify it, it's just the impact of the asthma symptoms. We have the triggers, we have the symptom experience, we have the symptom impact, and then the long-term consequences. Common triggers are our exertion, environmental, and health and emotional stat. Symptoms can be daytime, like coughing, chest tightness, and difficulty breathing can come in. Nighttime symptoms are bothersome, and that indicate the control of asthma. And those attacks are sudden, very frightening to the patient, and it affects the sleep and all that. During the attack, obviously, you come with the chest tightness, you can hear your own wheezing, and progress into difficulty breathing. Symptom impact, we can have physical impact as well as emotional impact, effect on the relationships, effect on your self, well-being, mental outcome, and activities. Sleep also becomes very important because you may not fall asleep, have trouble falling asleep, it's interrupted, and then quality of sleep suffers, so does the daytime consequences of lack of sleep. What are some of the long-term consequences? Patient's identity is affected. They start out because they don't feel well. They feel their role they are not able to fulfill. There is low self-esteem and low self-determination also. When it comes to mental health, we find that anxiety and depression is common in asthma patients. As I mentioned, in the elderly patients, the numbers can go up to 35%. These are guidelines, NIH guidelines for management. I may not go here, but mainly goes for what to monitor, what to assess, how to monitor, but major outcomes are we are measuring the exacerbation events, then composite score, like quality of life, then also look at healthcare utilization, like asthma-related visits in the clinic as well as medication use, and then pulmonary physiology, like the physical exam. Let's talk about asthma management. Risk factors are, we have to know them, like infections, we can take precautions, allergens, as we mentioned before, irritants like tobacco smoke, any strong odors, cold air, exercise, temperature changes, and others are like our comorbidities, reflux, stress, exposure to the violence. We see that in the kids, that they can land up in the emergency room if there is some family disruption. And then the airway pharmacology, bronchodilators, like beta agonist group, and then anti-inflammatory groups, anti-allergic group, and then currently major attention given on the biologic for the severe asthmatics. I don't feel that this is the place to discuss them all, but behavioral and self-management comes out more important. Asthma education, we have to give to the patients as well as the patients have to participate so we can empower them in the self-management. Asthma control test, which shows us our quality of life. And then the asthma diary, how often we are affected. Nutrition, exercise, sleep, all the other non-pharmacologic management. And then breathing exercises. Pranayama, I am from India, so pranayama becomes more common or easily understood. They're mainly using diaphragm to increase your breathing capacity and calms you down, helps you out with the stress reduction. We need to monitor them with the spirometry, peak flows, remote patient monitoring, focusing on quality of life. And comorbidities always run that. These inhalers, whoever is asthmatic in the family or the asthma patient themselves, you have seen them, use them. I don't need to go there. What are our challenges? Patients don't feel their symptoms. They are not correlated. They're not reading their own body. They're not cognizant. So they may go do certain things even when they are not feeling well. Have a cookout and is sitting in the smoky area and have trouble with the asthma at that night after the evidence. Not paying attention to the medications or the asthma plan when you're doing well. Using that more so only for emergencies rather than being on the control of medications. Multiple comorbidities again play into role. Depression is a constant challenge. Patients are not feeling up to doing anything. Forget about the medicines, not even activity, that's not. And access to care, mainly in Georgia, rural areas, that becomes a problem. We heard from the lady before doing the health informatics and technical things that they can help us. Here again, I'm doing I think I am repeating myself here. I do want to go to respiratory remote patient monitoring because it's a relatively new concept. What is involved? It's a very important key thing for the chronic care management. Focus is on the continuous care rather than the episodic, not only clinic visit 3 months, every 3 months or every 6 months if you're doing well. It goes into your quality day-to-day life. Promotes access to care no matter where you are. If you have a good signal, most of us have the cell phones, and it's an app that you use. It requires a patient education so that we can enroll the patient in the self-management and give them power to follow. The patients become curious and get involved in their own thing. Anytime you do spirometry, home spirometry at home, the monitoring system or the platform captures it, and there is instant submission. So the monitoring team can then report to the physician involved, and it can be escalated if somebody is in so-called yellow zone. All of us know green, yellow, red zone for asthma. So if somebody comes in yellow zone more than once, the patient is notified, and the physician is notified, escalating the care. If we reduce the emergency room visits, urgent care use, and the hospitalization, we are helping to reduce the economic burden while improving the quality of life. Now, what do we monitor? We are monitoring the quality of life. Why is it flipping so soon? Symptoms, free days, severity of symptoms, escalation interventions, missed school and work days, ER visits, and hospitalization. How do we do that? We monitor different parameters. Home spirometry, pulse ox, any other data can be also added. There is a lot of education of the family and patient, also the physician and the team. Then there are reimbursement codes from Medicare, mainly following the pandemic. And support team monitoring, escalations, and then the follow-ups. And why do we monitor? Again, reducing the risk, better asthma control, allocation of the healthcare provider resources, and less use of the ER visits, hospitalization, use of medication, thus the financial burden and increased access to the rural patients. This is one of the companies who is doing that. This is summarized slowly. Patient is enrolled here, gets monitored. If there are any indications, the physician is notified. Then they can decide whether the patient needs to come to the office, go to the ER, or guide it to the hospitalization. And I think that is my take-home message. Know your asthma, focus on self-care, smoking cessation if you're there, manage your comorbidities, and participate in preventive. Thank you, and questions? Yes?
What role do you think allergy testing has with asthma?
It does play. It depends upon when you take the initial history and look at the patient. There are patients who gives you symptoms or signs on their exams that you can prevent.
Do you think it should be done in every patient?
Not a must. Because if you go, a lot of times the trigger is infection, respiratory infection, and not necessarily the allergy. Because once like COVID or flu or something, our lining, our healthy lining, keeps coming back every 2 weeks. That's how we may say the cold may last 7 days or a week, but sometimes it goes beyond 2 weeks and depends upon the virus.
Now, with the monitoring, is that something that a physician can sign up for? Is there a fee for that? Or?
Well, good question. Because what you do is that here I feel you optimize your time. Whoever is the squeaky gets attention. See, we miss out on their quality of life in between the visits, right? So if you choose in your practice moderate to severe asthmatics, who are the frequent flyers of the emergency room, they can get qualified for being enrolled in the program. And once you enroll them, the team takes over, educates the patients on use of the app on the phone, the use of the home spirometer, and the monitoring team starts monitoring. If there are green check-ins, like green, yellow, and red, green zone, you don't do much. We just encourage the patient to stay adhered to the plan. They show up in yellow more than twice in a week, then it's a signal that we need to escalate the care. If they're in red zone, definite escalation. The monitoring team doesn't change anything. They just provide the connection between the patient and their provider.
Who does the team consist of? Is it physicians, nurse practitioners?
No, there are usually MAs, nurses, RTs. That's the company, they can do it. With the pandemic, Medicare has come up with the codes, and so is the insurance companies. There is RPM codes, and they have also come with RTM, like remote therapeutic codes, that the physician can get reimbursement.
Excellent. I had a question concerning the age progression with asthma. You spoke about as we women age that our asthma gets worse. Has there been, more vulnerabilities in seasons or?
No, see, as we age, what comes out is what comorbidities you have.
I see.
Comorbidities play a lot of things. Like osteoporotic people, you use inhaled steroids, then you have to watch out. Steroid thing, right? Diabetes, again, it's a worse thing. Like steroids will increase the glucose levels, but if you don't use the inhalers, your asthma gets worse. So that is more so. And then they're not taking care of themselves.
Gotcha, yeah.
Depression also comes in. So those are the things.
Is it similar with COPD?
Yeah. COPD also, respiratory illnesses are. When it comes to the women, that is the trouble. And all of us, our lung functions go down as we age.
Oh, okay.
That's an age, means it's a progression age-wise anyway. We lose some of the alveoli, we lose some of the things, muscles become weak. So it's a physiologic age-related changes also.
Okay, thank you.
Any other? Thank you. You want to tackle me?
Thank you. No,
Okay,
no.
okay,
No,
ladies.
I don't want to trigger my asthma.
Me neither.
All right,
Thank you so very much.
no problem.
for your insightful presentation. Everybody here is standing with an inhaler today.
Yes.
We've been talking about, I mean, this is really something, particularly for women. You know, I see as I get older, more need to use an inhaler, more need for some type of respiratory care. And I need to pay more attention. This really has come across to me today. Particularly, I don't want comorbidities to come up. I don't want this to progress. And so I thank you very much for sharing that information with us, because we have to be more vigilant and diligent when it comes to our self-care. So thank you.
Thank you, Dr.
Thank you.
Dipji.
Thank you, ladies.
What an amazing presentation. We have had so many wonderful presenters today. I am just blown away at the vast amount of information that I'm going to incorporate for my preventative maintenance.
You know, for all of you out there, this sounds great out there, but us sitting here, Dr. Marsh and I were just sitting off to the side, saying to each other, what an amazing day of some phenomenal, high-level, incredibly accomplished individuals we've had with us today. These are individuals who have been first in their field.
That's right.
To develop different modalities of treatment care for children, for women, and we are so blessed here at Georgia Commission on Women to have them come and impart their knowledge.
Yes.
We've heard some fantastic speakers today.
Yeah.
We've heard from
Dr. Barney Graham.
Barney Graham.
That was like a special treat for me. I kind of fangirled out a little bit. I had to get my selfie in there.
Yes.
Because I was reading his papers as I was going through medical school. And so it is, it was just so strange seeing him in person today.
But Dr. Marsh, not only
Such a
that,
pleasure.
listening to his stories
Yes.
of the individuals that he mentored,
Yes.
that was outstanding.
Yes. Dr. McKenzie, the one of the scientists that was integral in creating the COVID vaccine. And so he had known her since high school, which was so shocking and so wonderful to see her path within virology and within research and the significance. He let us know she wore a shirt that said, "One day a black woman would save the world," and she didn't even know that it would be her.
That is so true. And, you know, I want to share with you guys out there that we have had some preteens here, some
Yeah, that's
young.
great.
We've had some young attendees here with us.
Yeah.
And Dr. Graham took time
Yeah.
to go outside and show them how the COVID vaccine was developed.
That's correct.
And took pictures with them. And the one thing I said to myself, just surveying the scene, is he is standing here influencing the mind of a young girl of color who will one day look back at those pictures and say, this person took time to speak with me, possibly even mentor me, and you're looking at the virologists, the vaccinologists of tomorrow. And that's how mentoring and advocacy, that's the role that we play. And it's very important in the work that we do. And for those of you out there, you don't know who it is, whose life you're going to touch. And it is so important to do that level of work as well.
So true, so true. But thank you again, Dr. Devgi. We are going to keep the program running, and I have the privilege to present to everyone Dr. Jane Kearney. She is the founder of UROS, that is Mental Health Services, LLC, a private practice, and she shared with me
what the acronym UROSE meant, and it's so impactful, and I'm so happy to share it with you right now, the universal recycling of self-existence. I am excited to see what she has to say because she provides telemental health services and in-person services to clients at her private practice of UROS. And she specializes in cognitive behavioral therapy and focuses solutions and may use alternative concepts. So maybe we'll get to learn some of those today, but they're empirically proven to improve and provide positive self-esteem, self-awareness in women. And these women who are, if you're experiencing domestic violence, along with improvement of your communication skills, that will encourage women to embrace their individuality. So, with none other ado, let's welcome to the summit Dr. Kearney.
And as she comes up, I want to thank her publicly. Come on up. Come on up. She doesn't even know what I'm going to say.
Oh, what you gonna say?
I just want to say to everyone out there that I thank you for the work that you do. Last week, you called me out the blue to tell me that you were thinking of me and to check on me, just like that. And I said, wow, you know, the Lord always knows to send something right when you need it. And he sent you that day. I just needed to know that someone was thinking of me and that it was going to be okay that day. And I'm looking forward to making use of some of your services because it is important. I believe everyone should be in therapy, even if you think you're doing great.
Yes.
Get some therapy.
Get some
so I'll
therapy.
be coming, okay?
All right.
So thank you so much.
You're so
okay?
welcome.
Yes, I
You're
appreciate
so
you.
welcome. It's a blessing to be here today, and thank you for inviting me to come and
Absolutely.
speak on mental health. Yes, yes. Like she said, my name is Jane Kearney. I am the owner of UROS Mental Health Services. My office is down in Fayetteville area, and it's just been an honor and a pleasure being here today. I have been here all day long, and I have heard some great, great speakers. And so today I am going to be talking to you about teen suicide and the silent cry. I don't know if I'm working this thing right, but let me see. Okay. Okay. It's talking about what is teen suicide. We have so many youth who are suicidal, and I don't think the thing flipped over. Let's go to the next one. Okay. There we go. All right. Thank you. What is teen suicidal? Teen suicide is when a young teen thinks about committing suicide without even making a plan or anything. It's just a death that they do on purpose. This is something that so many of our youth are doing today, and they attempt to do suicide and to take on their own life. A teen may have thoughts of wanting to die. This is called suicide ideation, and we have so many teens who are having suicide ideation. I work with children in the school system, and I come across so many of the students who have these thoughts of suicide, or maybe because of the fact that so much is going on in their life. When we look at teen suicide intent and the pain, suicide is the second leading cause of death for children, adolescents, and young adults. People from the age of 10 to 24 accounts for 14% of suicide. High school students have a 22% rate who were seriously thinking about suicide. 10% attempt at least once. More than 48,000 people died in 2021 by suicide. For youth and young adults, male accounts for 75% of suicide due to the fact that male commits it and go through the whole process of committing suicide than the female. And there was only 58% of the hospitalizations for females. Female teens, females are high risk for having suicidal thoughts and behavior than males due to the fact that there are so many things that's going on in our young women's lives. They might be in a relationship, especially as a teenager, and they may get their heart broken, or they may be going through some kind of drama, or maybe they have things going on at home. But what I have found out to be is that it don't just start at them as being a teenager. It really starts, because I work with young adults as well, with the children. They may be 5 years old, 6 years old, or whatever. There are so many things that are triggering and causing the children to become suicidal. They might want to be with their mother, their father that's not in the home. And not having that parent, it's like it make them feel like they may have it may be their fault. Oh, I want my mom and I can't have my mom because mom and dad are having a problem in the home and they don't know how to reconcile. Also, the drama or the parent may be in home being argumentative, fighting. The trauma that the mother and the father are going through, don't you know that these children feel that effect? The children feels the pain, feel the drama, feel the anger, feel all of this energy that is in the home. It is affecting the child as well. And so many times parents are not thinking about that because they're all caught up in their own stuff. They're caught up in their own things that's going on. They just don't even realize that the child is even going through anything. So we just see that 3 out of 10 females seriously think about attempting suicide for the past 24 had a plan. They had a plan of how they're going to do it. This is a 60% increase in the past decade. 60%, that's a lot. Male teens are 4 times likely to die from suicides than girls. As an example, public health statistics from the United States report that the rate of suicide death among male ages 10 to 19 years was 7 per 100,000, and for female was 2 per 100,000. I think, but right before COVID, I had went into the school system, and one of the young men was very involved in school. He was part of the drum team, and his mother had died at Christmas. But anyway, he committed suicide because of the fact that he was sad, depressed. Nobody really noticed that this young man was going through because he was very energetic, he was popular and everything, but they come to school, this young man had committed suicide. Then the following week, we had another student to commit suicide because we just have to pay attention. We don't realize that there are so many signs that are there, but we're so busy looking at the fun and everybody having a good time, and so we don't realize that they have these things going on. So we have to say, we have to talk about suicide. Is it all right to mention or talk about suicide? Yes, it is. It's not going to make the person commit suicide because you talk about it. It's just the fact that it's the idea that you asking a child or adolescent, are they depressed or thinking about suicide? It will allow you to help them. And why is it important to ask? Are you feeling sad or depressed? Are you thinking about hurting yourself or killing yourself? Have you even thought about killing yourself? Ask these questions because of the fact that they don't answer the questions. They don't really come to you and say, hey, I'm feeling suicidal, but there are going to be some symptoms there with this patient or with this client that may be suicidal, because there are so many signs that are there, but we miss it. We miss it as a parent, we miss it as friends, and we miss it as teachers because they are there. Things to look for in those who are suicidal. Depression is the most common sign in those who are suicidal and often diagnosed or treated. Depression. Change in the behavior or the entire new behavior. If they behavior change, they start doing things they haven't usually done before. They start to act in a certain way they didn't act. They start to give away their things, because of depression and giving away things and having these things going on in their life. We don't realize that these child have these thoughts in their minds. Feeling hopeless. I don't feel like I belong anymore. Or, like I said earlier, being in a relationship, it's hard for adults to really deal with drama, deal with depression, deal with domestic violence going on in the home. And when a young girl or young boy get in a relationship, then they have all these different things going on. Somebody leave them abruptly, we call it ghosting, They ghost them, and they don't know how to handle that. So guess what they do? Most of the young girls, they may try to take some kind of drug to commit suicide, or they may cut themselves, because we have a lot of cutters that happens. And so these girls are going through things because they feel like they have body imagery, whereas that they feel like they're not pretty enough, and they don't know why this person has left them. And so if an adult has problem dealing with things going on in the home, it's so much harder for even young people to even fathom or even think about dealing with things that adult can really deal with. Being burdened to others. Being a burden in the home. What have I done? They've been ridiculed at home. Calling names. Being verbally abused, mentally abused, emotional abuse. There are so many things, and there is so much. When we say unbearable pain, then somebody may have died. They may have died in a car accident, and they was alive maybe 10 or 15 minutes ago. Then all of a sudden, somebody is taken away from you out of your life. And this is so many things that we can just look at when we see that our children are really hurting, and that silent cry is there. What causes youth to attempt suicide? Having mental health disorder, depression, anxiety, post-traumatic stress disorder, impulsive stress, and self-doubt. Now, we have so many of our youth, male and female, have self-doubt. And so how do we build these young people up? How do we increase their self-esteem and build them up to where they can be able to love themselves, to be able to embrace who they are right then? And it starts when they're young. So we have to put in our minds and teach them as they grow older that you are somebody, and make them feel good about themselves. Yes, they may get it wrong at 3 years old, but that don't mean that they just acting like a typical 3-year-old. And as they grow older, and one thing I have found out is that when you get a child that you constantly give things to and pamper and baby the child at 1-year-old, 2-year-old, 3-year-old, 4-year-old, and then the child becomes 5-year-old, you begin to say no to this child. This child is not used to the word no because of the fact that we have groomed them of giving them everything they want. And now this child don't know how to process. You have stopped giving them the things that they want. And so they become angry, they become combative, they become opposition defiant, and all these behaviors begin. And they take all of these behaviors up into their teens years. So this is why it's so good, it's so important to address it while they're young. We miss the sign, and they're bringing them all the way up from toddlers into their teenage years. And they become depressed, and they have held all this stuff in, and we just say this is called childhood trauma that has never been dealt with. From a little, from 7, 8, 9, 10 years old, they have never been dealt with, and we feel like sometimes parents can be in denial that the child may need help. That my child don't need no therapy, my child don't need no medication. I don't really just push medication, but sometimes the in chemical imbalancement can cause the cognition of the person to be off, and to where they can become suicidal. Loss of a relationship, as we speak. They lost a parent, whether in death, whether in a divorce. It affects the child. Even though mom and dad can't get along anymore, now the child has to process my dad or my mom is no longer in the home. I don't know how to deal with that. I just want my mom and my dad back together again. So if they're not back together again, then I don't even want to be here. I don't even want to be born anymore. What makes a 5-year-old or a 7-year-old say they don't want to be here no more? What do they know about suicide? You know, they are making these statements at a very young age, not just in teenage years. I'm hearing this. It is very sad. You don't even know what life is really all about. You haven't been living but 5, 6, 7, 8, 10 years. You haven't even been living. You haven't never even experienced life before, but you don't want to live. And this is so important, so very important. Serious illness and pain. You got children that may be going through some kind of illness to where they don't know how to cope with the pain. Or they feel like being sick and ill is a burden upon their family. I just don't want to be here anymore. Change in the family's dynamics. Like I mentioned, divorce, moving to a new town. Or moving to a new town, that means there is no consistency. I have children that's parents moving from this town, from this state to this state, and what happens is that you have taken my friends from me. I don't have no stability. I don't have no consistency in my life, to where they can become, it really affect them mentally, to whereas they begin to have a high degree of anxiety, with depression, and they don't know how to function with the anxiety, don't know what's going on in their body, and this will cause them to maybe take some overdose of drugs or want to commit suicide. They become suicidal because they don't know how to handle it. Social isolation. Parents, we know we have to work. But so many times our children are isolated within the home, and they don't have anybody around them. And not having nobody around them, and they at home alone, no communications or anything like that, it causes the child mind to play games on them. It makes them think that they don't want to be here anymore. They have to have socialization. It's okay, we say we want to homeschool our children. That's wonderful and great, but give them some kind of extra curriculum so they can be involved and know how to communicate with other children and with other people. Give them some kind of social skill. They need that. Being bullied at school and on social media. And this is just a big high rise of being bullied on social media. And because social media makes young girls feel like that they talk about them, break down their self-esteem, break down their self-image to make them feel bad or how they look. And what I've learned about the young girl with the self-imaging part is that they became, in elementary school, being bullied, it takes it on into as they become teenagers. It's like, what made you feel that you don't like yourself anymore? What happened? And most of the time that I'm hearing is that somebody told them in elementary school that they were ugly. Somebody told them in elementary school that your body is made funny. And being bullied like that has affected a lot of our youth mind to whereas they don't like themselves. And this is when we come to the body imagery. You know, I have several students, young people that say that I don't like my arms, or I don't like my face, or I don't like my legs because of what somebody said. And they are beautiful, beautiful young ladies. And it's more so of the young ladies than it is of the men that has body imagery. But I'm sure that males have body imagery as well. You know, the type of video games they play. Oh, Fortnite, all these video games and all the killing and everything that's in these games can trigger our young people's mind to make them become suicidal. And so we have to be careful and monitor our children while they're in the rooms playing these games, or even on social media as well, because we don't know what they're doing in there. Because so many times, parents, you're at home, your child is in a room, you don't even see your child all day long. All day long, they're in the room, and their mind is just continually focused on the game or on social media. So we have to be mindful of what our children are doing in their rooms. Some of the suicide prevention. Now, if you have a weapon in your home, and most people do, and I provide you safe locks or remove all weapons within the home, because the gun is the #1 thing that males use for suicide. It's the #1 thing that they use. Remove all drugs and medication in a safe place. Dispose expired or unused medication in the home. Communicate effectively by listening and watching the behavior of the person. Everyone plays a role in the prevention. Affecting, coping, problem-solving skills, we have to have this because of the fact that we know that when you have these instruments or these drugs in the home, and we have to have a plan in place to where we can be able to communicate with our children. Extracurriculum, sports or club or volunteer will actually keep our children busy. Keep them busy. You know, I have children, I have a granddaughter, she's busy all the time. We keep them busy because you ever heard this old saying, an idle mind is a devil playground? Because it affects your mind. So this is when we was talking earlier that I use cognitive behavior theories, because if we can change the way that you think about yourself, the way you view yourself, then you're going to change your behavior or how you respond to yourself. Support from families and friends. Having that support from your family and friends there with you, motivating you, encouraging you, building you up, making you feel that you are a part of, making you feel like you belong, included in school communities and social groups, being involved in different things, being active. And sometimes they might be shy, but I noticed that a lot of children, we put them in some kind of sports or some kind of activity that they may be doing, they begin to thrive so much better, so much better. Suicide to the extreme. Suicide threats. How many times have you heard somebody say, I want to kill myself? And we just take it like, oh, you ain't going to do nothing. Go somewhere and sit down. You ain't talking about nothing. Anytime somebody say, I want to kill yourself, take it seriously. They're not joking. They might be joking and playing like it, but seriously, we take it very seriously, because in school, when a child make a suicide threat, we take it very seriously. We go into action where we have to call a parent, we have to do a 1013, or we have to call the police, we have to call the MRA, the fire department. We have to call people in to come in to help with that. Suicide attempt, such as self-harm action, or non-self-harm action. So the non-self-harm action is when you see a lot of young girls wear hoodies, long sleeves, big clothes. And a lot of times we don't know that our children are cutting. This is so very seriously. They cut themselves, they wear these big shirts, they cut their legs in between their thighs. They got different places that you don't even see that they're cutting. Check your child bodies, especially if you don't never see it and they're wearing these these big overgrown sweatshirts that they're wearing. Sleeping too much or too little. Staying in the bed all the time, don't want to get up, don't want to do nothing, don't want to go nowhere, then they're in a state of depression. Withdrawn or isolated. So we have to watch these different signs. display rage or extreme mood swings. You know, one minute you happy, next minute you sad, you down, and we don't know what's really going on with you. These are some of the signs that we may think that, oh, they might be having a bad day or something like that, but just take it very seriously, that these are some of the signs that is affecting our children to be suicidal. Subjective to various childhood adversities was correlated with a greater risk of suicide, such as death. A lot of times our youth do not know how to process grief because of their mind is not at that stage of even some adults. Many adults can't process grief, especially when they come to a parent or a loved one or something like that. Grief is hard. And not having something in place to help you, give you the tools or give you some techniques that you need to really kind of overcome grief, then it's hard to get past that stage, whereas the space that used to occupy someone that you love is no longer occupied by that person. So how do I deal with this? How do I transition through going through a process of grief? And a lot of children don't know how to do that. And substance abuse. The number one substance abuse that a person takes to commit suicide, you will be surprised. Aspirins, Tylenol. That's something right at home, something on your dresser, something that you can get out the medicine cabinet, something you can go Walgreens or somewhere and buy. They just take a lot of them. That's number one. Number two is ibuprofen. Ibuprofen. I learned this, like you had said, I learned this, I was surprised about it. And some kind of antidepressant medication. There are several more pills that they may take, but those simple things that we have in our home that we never would think that these children would take to commit suicide. Treating suicide. Depression and suicidal ideation can be treated. You have the disorder and the symptoms diagnosed. If you see that your child has something going on, take them to their primary doctor, and the primary doctor can refer them to counseling, or a lot of primary doctors are treating mental disorders now. You know, it's just become a part of the practice because due to COVID, a whole lot of things came out the woodwork with mental health. It increased tremendously. I have never seen so much mental health, anxiety and depression in a long time. But we have post-COVID depression, post-COVID anxiety. Everybody we come across, some anxiety, some people have anxiety, might not have depression. Some people have depression, may not have anxiety. So we have these disorders that have really increased. We create a treatment plan to effectively treat the diagnosis. So we talk to the parent, we talk to the child, and we do like a initial assessment, and we get all the information that we need that is really going on with the child. And especially when I be doing the counseling with children or with teenagers, is that I talk to the parent and I talk to the child and I talk to them separately. So, because a lot of times children would tell me things that they might not want to discuss in the presence of their parent, and build that rapport with them so we can be able to really get to the root problem. Because depression is the symptoms of something. It's not the root problem. So we want to get to the root problems of what's really going on in the home, what's really going on with you mentally, and what is really going on so you can open up and build that positive rapport with children and with teenagers. Medication may be prescribed to stabilize the cognitive state and balance the mood. Some children do need medication because of the fact that there may be some genetics things going on, mental health. Some of the parents, some parents may be bipolar. Some parents may have borderline personality disorder. Some parents may be schizophrenic. We just got different things there that may have trickled down through the genes and may affect the child mentally. So we have to be mindful of all of that. And a whole lot of love, whole lot of laughter, and a whole lot of self-care. It's so important. Self-care, I emphasize it and can't emphasize it enough. And not only that, having that self-care, being able to communicate with our youth is so important. Because if you have that open relationship where you can communicate, not to ridicule, not to put down, not to be argumentative, but to be there to hear and listen to what they're saying. Because as I say, within communication with our youth, you got to be able to hear them. Not only do you have to hear them, you have to be able to comprehend what they're saying. And your tone of voice is so important because you don't want to shut them down. Because when you start to yelling at them, start to calling them names, and start telling them ain't nothing wrong with you, go somewhere and sit down, just because you're the parent now. You know how parent, boy, go somewhere and sit down. I don't want to hear there ain't nothing wrong with you. But there is something wrong. They're telling you something wrong. But a lot of times we just throw it off like it ain't nothing. You don't know what you're talking about. You're just going through something right now. And that child is crying out, and that's where the silent cry come in. We're not hearing the cry. Hear their cry, because they are telling us that something is wrong. Even little children tell you, isn't it amazing? A little child will tell you something is wrong. You say, oh, mama, something is wrong. And we say, okay, then baby, we just rub their head and let them go on. But then again, they're crying out. You know someone who needs help? Or do you need help? Because a lot of times we think that we got it going on. And a lot of times we may be depressed. We have thoughts of suicide. And I'm sure that at one time, or maybe so in your life, you might have said, I don't know if I can make it no more. I can't, this is too much. This is so overwhelming. And how many times have you said, or maybe not you, maybe you, somebody else, have said that I can't do this anymore? Most of the time, you know, we may have said those things to ourselves, but we want to be mindful to listen to our youth. Listen to their cry, because there are things in place. We have the suicide hotline. We call it a lifeline. It's 988 Suicide Crisis Hotline. You have the National Suicide Prevention Lifeline, TALK. And also, what else we do? We do screening as well. We do the screening. It's a CSSR suicide screening that we use when we do for our youth or for anybody that's suicidal. And we get the information that we need. So have you ever attempted suicide? If you did, how many times have you had any thoughts of suicide? And so when you come in contact with somebody that's talking or acting a certain way, ask them. It's okay. Have you had any suicidal thoughts? The first thing I ask any of my clients when they come to me, before we get started, I need to know, have you had any suicidal thoughts? Have you tried to attempt suicide? And I get all this information straight up front before, because I want to know what kind of client that I'm dealing with. And, you know, with the youth, they may say no or whatever, and sometimes they're afraid, and as we go further in a conversation, then it might slip in the conversation. And I'm like, didn't you just tell me you didn't have suicide thought? But I don't say that. But but listening and asking the right kind of questions will allow them to open up to tell you that I need help. I need help. And so many of our youth are crying out, and I want you to be able to hear their silent cry. Watch their body language, because a lot of times they can speak more by not saying nothing, because you got that nonverbal communication going on, and you're watching, you're seeing, and you should know your children's behavior. You should be able to recognize it when you see it. And so I'm here to tell you today, be mindful and be open to our youth and their behavior, how they're acting out, and what they're doing, and give them the attention that they need. And also, you know, we grew up being at the dinner table. That's the best time to find out what's going on in your youth, in your children's life, at the dinner table. So many people are eating in the bedroom and not having that connection. How was your day? What you had going on? How are you doing today? You know, so come on back to the dinner table and eat and find out what's going on in your child's life. You know, take that time out and go for a walk or go for a ride or something with your child, especially when you see the child have something going on. You know, so do this. Do this for your child. Do this for yourself, because you may save this child's life, and they might decide to open up, because so many children are shutting down with their parents, especially when they become teenagers. The hormones changes, and they think they know everything. They think they got it all going on, and it's okay because we did it too. And so my thing is that we still have to give them that space that where they can still find themselves, but then we just be there to help them, guide them along the way, but in a positive way. But in a way, even though they may have their little thing going on, but we have to sometimes step back, mom and dads. We have to step back and be able to say, okay, then I'm going to give you your room to grow, but I'm here if you need me, and I'm also here to give you the tools that you need to mature and become the great man and the great woman that you can be. So anyway, like I said, my name is Miss Jane, and that's what my students call me. And my student, I think I missed the slide. Let me see, go back. I don't know if it's on here. I had my information on there, but it's not on there now. But anyway, my name is Miss Jane. They call me your therapist on the move. Oh, it's down there. Go down a little bit more. Oh, there it is. Let me see. Oh, there it is. So this is URO's Mental Health Service. If you want to get in touch with me, you can scan this Q bar. You can reach me from here, and I am here of service if you need me. Thank you all so much for receiving me, and you all have a wonderful day. Any questions?
Comment. I see a lot of
It's not on.
lot of parents are giving the kids a iPhone or a pad, and instead of talking to them.
Mm-hmm.
And I think they are programming the kids to lose their communicating skill.
Mm-hmm.
Because the parents themselves are busy or may not know how to intervene, and that's really hardening me up.
Mm-hmm.
Because that's why one of the things can be that we are seeing a rise in the thing. Because they're missing the communication, one-on-one talk with the kids, spending time alone.
Mm-hmm.
Spending time alone with your child, that is missing quality time.
Yes, it is. Yes, it is. And you know, since you said that, you go in a restaurant or go places, and even with the babies, the first thing you see is an iPod or some kind of
Yeah.
device in front of the child's mind, in front of the child's face, and that's what they're doing, and everybody's communicating. There's some communication
They tune
with the
out.
children.
They tune out totally.
Mm-hmm. Yes, it is. I see it all the time.
Yeah.
Yep, and that bothers me as well.
Now, one of the other things was having the normal hormonal changes in the teenagers, giving the mood swings, and the child who's at risk for suicide or mental health behavior. What are the cues you may guide us on?
Some of the cues that you may see is that they shut down. And so, and especially when you see that they're active or whatever, they shut down. And another thing is anxiety. Oh, anxiety is really, really major, because of every child come across have anxiety. And so the thing about it is really, I have to, when I get with the children, I give them the tools how to cope with anxiety, but I also teach them what anxiety is and let them know that anxiety is just a result of something that you may be worried about, that you're fearful of, or some kind of new event or something that's going on. So I have to give them those tools, but that's the main trigger that I see is anxiety.
Ms. Jane, thank you so much for your very insightful presentation. And I don't have children, but I have a lot of nieces and nephews and young adults that I mentor.
Mm-hmm.
And sometimes I need to check myself, because I may look at them sometimes and say, what is the problem? What's the problem? When I was your age and younger, I was a latchkey kid of a single parent.
Mm-hmm.
She didn't know what I was doing. talking to me? Well, she didn't have time for that.
Mm-hmm.
And growing up in New York, you are on your own. You could be out doing whatever. And it just seems to me I have to reframe my way of thinking, because when we were in high school, we were so resilient. We were on our own. It just seemed like such a different time.
Mm-hmm.
And I think it makes it difficult for intergenerational communication. And parents of these children who grew up just like me, now you have children who have anxiety, and anxiety over what? What's the issue here? So I think that is a big part of the problem. We're speaking different languages from one generation to the next. You have millennials trying to, what are we now? I don't even know what I am now.
Generation Y.
I'm Gen X, Y, Z, ZZ, XYZ. I don't even know what I am. ABC. We're about to go back to the beginning. But what I want to know is, what do you think the prescription is for us to be able to understand and hear them? Like, they're worried about climate change. You know, big ticket things like this, because they are listening to my nieces and nephews. They're really concerned about what the world's future is going to be for them. You wouldn't really think, we weren't thinking about those things, the world we're being left.
Yeah.
And they're really concerned about these things that we. So how do we understand, even when we're listening, it's not just listening, it's not just hearing, it's listening, comprehending, and understanding what it is that they're talking about, which sometimes is a totally different language.
Mm-hmm. You know, there is a big generation gap, you know, because if I look at the generation behind me, and which is my mother, they talk a different language than I talk, and then your grandparents talk a different language than what they talk to your mother. And so the thing about it with me, that I educate myself. I listen to, they tell me about certain things. I listen to their music. What you call the code, they be talking, they language that they talk. Tell me what that means. You know, I'm like, really? I get involved. Being involved with what they're doing and how they're doing and how they feel and what they think. I'm getting off into, I'm a mind person, so I'm getting off into their mind, into their world, so that I would know how to communicate with them and we click. I love working with the teenagers because I can click with them, because I know I'm seeing how you're thinking, you know, and see what happens with what happened to the generation between the gap is that a lot of times we throw up in their faces, well, we don't do it like that. Well, when I was growing up, we did it like this. They don't want to hear that. That's you ancient to them. So we have to listen to them instead of say, well, you know what? I'm glad you said, well, when I was, you can reword it. Well, when I was growing up, we did so and so, but you just educated me that the world is evolving. And so we have to evolve with things, just like the computer, electronics, and all this stuff is evolving. The minds of our young people is on another whole different page. So we have to evolve right along with them.
I used to feel, because being a pediatrician, I kind of was aware of this. I would feel like there is like every year a new model comes of the car. You can see the kids, 2005 edition, 2007 edition, 2010 edition, the difference, their awareness, they're just different kids.
They're different kids, and we got to evolve right along with them and love them right there where they at. Right there where they at. And so, okay then, well, show me how you do it. Well, show me what you're talking about. I'm not comprehending it. So you show me what you're talking about so I can get it. So that's how it's just change of communication. That help you?
Very, very much so. I'm on my own personal journey to be able, because I'm also an educator. And so it is very important that I understand, because I'm educating young adults. And just like you, I think I'm gonna always be the cool auntie, because like you, I listen to the music and I try to talk the language and I spend time with them. And you know, although I'm not a parent, I understand that the way that parents have to parent now is different. It cannot be like how my mother parented me. Okay, do so, I'll be back.
And they did.
No.
Not
You have to be on top of. I watch my friends and it's like, you are so involved in your child's life. I mean, can't we just go for brunch? No. And you got to keep them busy.
You got to keep them
Running, track,
dancing.
Dance class, knitting, drumming, toenail painting, whatever it is, you got to be involved in it and keep them engaged, and you have to be immersed in what they're doing as well.
We have an online question. It says, does it help I'm reducing negative thoughts and emotions to use the language died by suicide or killed themselves versus committed suicide?
Died by suicide. Died by suicide is the right way to put that, because we can commit a lot of things, but we don't want to say commit suicide. We want to say he died by suicide. Died by suicide is like you say, as a doctor say, when you go and you have to examine the person when they died on the bed from a heart attack. So what do you say? He died by so-and-so, so-and-so. So as being in the professional, we die by suicide, because suicide is the cause of the death. Yeah. All right. Thank you all so much.
Thank you, Dr. Kearney. I mean, that was truly incredible. We're talking about preventative maintenance,
Yes.
learning how to speak to teens about suicide and mental health, and those signs and other conditions associated with the symptoms of rage and, you know, change in behavior and all of these wonderful wisdoms and nuggets that we are taking away from Dr. Kearney's presentation.
You know, Dr. Marsh, it is so important.
Okay.
You know, I know that we've said this for each and every speaker, but for this one in particular, it is absolutely critical that we are immersed in the lives of our children, our mentees, our nieces and nephews, whoever it is, so that we can help to bridge that intergenerational gap.
Yes.
It is the only way that we're going to ensure a future legacy to care for us as we get older.
That's right.
These kids need support.
Yes, they do.
So there's a lot that we have to give to them, and there's a lot for us to learn from them. There's no harm in listening to the music or understanding, you know, the fashion or the lingo.
Yes,
No
I
harm
love
in
the
that.
code language. They come up with such innovative terms these days.
It truly is a different language, absolutely.
But I am going to continue. I have the pleasure of presenting Carla Jacobs. Carla Jacobs is a native Georgian whose many roles include freelance writer, soccer mom, and community volunteer. Governor Nathan Deal appointed her to the Georgia Commission on Women in 2012. And she was reappointed in 2016. Carla
is the former chair of the Commission's Education Committee. So that is awesome. She likes to focus her attention on education issues, particularly those affecting students in the K to 12 areas and gifted students. A lifetime athlete. Ooh, I want to know what sport. That's going to be fun. She's also interested in policy areas concerning health and fitness. Carla represents the Commission on the Criminal Justice Coordinating Council statewide Human Trafficking Task Force. That's a mouthful, but I am excited to learn a little bit more about that task force. And she served as chair of the commission from 2015 to 2018. Carla Jacobs, I would love to invite you to this front stage. Yeah.
Awesome. Thank you. Very glad to see you guys.
Thanks. Thanks for being with us today.
Are
Welcome.
we ready to get started?
Yes, indeed.
Excellent. Excellent. Well, good afternoon, everybody. So glad you guys are here with us today. We've had some fantastic presentations, and I get to join you for the last one of the day. So I'm super excited to come and talk to you guys about human trafficking and a community approach to human trafficking that we can take back to our cities, to our counties, to our school systems, and do what we need to do to prevent human trafficking in our communities. As I was introduced, my name is Carla Jacobs. I am a commissioner on the Georgia Commission on Women. And in that role, I also serve on the Criminal Justice Coordinating Council's statewide Human Trafficking Task Force and also the Georgia Coalition to Combat Human Trafficking. So those are our two big task forces that bring together victim services providers, advocates, state agencies, law enforcement, prosecutors, people across the state who are working to combat human trafficking in Georgia. So what's Georgia been doing to combat human trafficking? We have been doing a lot, and we've really revved things up with First Lady Marty Kemp's initiatives to combat human trafficking. She has made human trafficking one of her pillars of the work that she's doing as Georgia's First Lady. And as First Lady, she created the Grace Commission, and this brings state leaders from across the state to look at what we can do legislatively to combat human trafficking. But we've been working on the human trafficking issue for more than 10 years, really digging in. Georgia legislators, advocates, we've worked together to move Georgia from having some of the laxest human trafficking laws in the nation to some of the strongest in the nation. So under Georgia law, child victims of sex trafficking can no longer be charged with prostitution, thanks to a change in the Georgia Code in 2019. Georgia law now consistently recognizes that children and youth under 18 years old cannot consent to prostitution and cannot be charged with prostitution. So we are treating our trafficking victims as victims now, victims of a crime, and not as criminals themselves. One of the first things we did was create a law that requires hotels, bars, transportation hubs like the airport, the buses, train stations, and adult entertainment establishments. It requires them to post the human trafficking hotline number in a public and conspicuous place. So that has helped us a lot in helping people reach our hotlines. Georgia has also increased penalties for sellers involved in trafficking. Georgia law was recently amended to increase the penalties for those pimping, which is selling sex, pandering, which is buying sex, of 16 and 17-year-olds. Those penalties have been increased to 10 to 30 years. These penalties are now the same as for those guilty of pimping or pandering a child under the age of 16. So the penalty for trafficking children and youth under 18 years old is now 20 to 50 years or life. So we've really strengthened those laws. We've also increased penalties for those who exploit an adult by buying or selling them for sex. So these are, again, traffickers, particularly not just those on the selling side of the transaction, but those on the buying side as well. And repeat offenders will be charged with a felony. We've also strengthened our laws to provide vacatur relief for victims who are convicted of crimes as a result of their trafficking experience. So for a lot of trafficking victims, they also carry along with them maybe a conviction for drug possession or theft or things like that. And having that record makes it very difficult for them to get housing, to get jobs, to really reintegrate back into life after they have been pulled out of the life, the sex trafficking life, and the life of a trafficking victim. So Georgia provides vacatur relief for victims to have those convictions vacated. And last year we had a great presentation on vacatur relief, so you can flip back to last year's summit and see a presentation on how vacatur relief works in Georgia. This recent 2023 session had some important legislation in it. Senate Bill 42, which was carried by Senator Mike Hodges, who is Governor Kemp's floor leader in the Georgia Senate. That law was passed and signed. It increases fines for businesses or establishments who are required to post the human trafficking hotline number and fail to do so. So it's made it more expensive for these different businesses not to comply with the notification law. Senate Bill 36, which was sponsored and carried by Senator Randy Robertson, it passed the Senate, but it has not yet passed the House. So because of the way the session works, it will start next year in 2024, the 2024 legislative session. It will start in the House Judiciary Non-Civil Committee. So what that particular piece of legislation does is it increases the penalties related to pimping and pandering. We've already made them more extensive. It's now going to increase those to make it an even more difficult for those convicted of pimping and pandering. It strengthens the vacatur laws for victims of human trafficking, and it provides for certain restrictions of the criminal history records for victims of human trafficking. Okay, so I want you to put on your concerned citizen hat for just a minute, and we're going to talk about some approaches that communities can take, and I want you to think about these questions as we go through this presentation. So human trafficking prevention requires more than a tactical response. It requires a holistic community-based approach. So I want you to think about, while we're talking about human trafficking, so what are my community's unique vulnerabilities? Who in my community is likely to encounter trafficking victims? And what training does your community need? So how do we reach these folks that are most likely to encounter trafficking victims and provide training for them? So I want you to think about that. Now, for myself, I live in Marietta, and some of my community's unique vulnerabilities are we have a high poverty rate in our city school system. We have a major sports venue. We have the Braves Stadium in our community, so that brings in lots of folks from outside of our community into our community. And we also have incidents of repeated trafficking activity in some of our local hotels, particularly one that has had some problems recently. So those are the three things that we think about in our community as being vulnerabilities, and how would we address those with training. So I want to take a minute to talk about who's at risk for human trafficking. Basically, all types of children are at risk for trafficking for different reasons. Particularly, access to the internet makes more of our children vulnerable to being approached by those that would exploit them. But we think of, we want to think about some particular risks. So looking at teen child A and looking at teen child B, think about which one you think would have significant risk factors for exploitation. And I know you probably have already guessed that it's a trick question. They're both vulnerable and both at risk. Teen A is at risk, striving for independence, using the internet a lot, is really wanting more friends, wanting a significant other. That makes this child a little more at risk. Teen child B is the one that most people would pick as the one that's most at risk. They don't live with their parents, poverty, older sibling in a gang, and a history of physical and sexual abuse. So both of these types of youth are at risk, and we just need to keep our eyes open. Okay, so who is exploited? You can see it kind of runs the gamut, but there's some who are a little bit more at risk than others. So up to 33% of the homeless and runaway youth experience commercial sexual exploitation. Homelessness, being a runaway, is a major, major risk factor because a lot of these youth and young people will feel that they need to participate in what we call survival sex for things like food, for shelter, for those types of things. So runaway youth, homeless youth are particularly vulnerable. Homelessness among LGBT youth is also a serious problem. We know that about 20 to 40% of runaway and homeless youth in the U.S. are LGBTQ+. A lot of reasons for that. Some of it is their families have thrown them out. They don't have access to a big support group because of their LGBTQ status. Transgender youth also face additional vulnerabilities because they're not likely to have their medical needs met and are more likely to face problems finding a job. So some of the things that make these particular youth at greater risk is they lack financial resources in many instances. A lot of them, because they're runaways or homeless, they may have an incomplete education. They may be lacking in job skills. And they may have nowhere to go. Mom and dad have thrown them out, and they don't have anywhere else to go but the streets. The one that is, I think, surprising and really hard to wrap your brain around is some of these kids are on the street because they're fleeing abuse at home. They feel safer on the streets. They feel the abuse they're experiencing on the streets is somehow less bad than what they experience in their home. So, they're escaping abuse. They may be escaping family-facilitated trafficking and exploitation. Mom may be selling access to her child in exchange for drugs. Child may be sent out with the landlord to cover a rent payment, those types of things. So a lot of these kids who are on the street because things are particularly bad at home. So some of the risk factors that we see fall in three categories. So individual, environmental, and social. Individual risk factors are things that you would think, abuse and neglect. We know in Georgia that 80 to 90% of trafficked youth have been sexually abused before they are trafficked. It happened in their past at some point, and that leaves them extremely vulnerable to being exploited later in their youth. Other individual risk factors are things like mental illness, prior traumatic events, having a developmental disability, drug or alcohol use, and being homeless or a runaway. Environmental risk factors are those that come from the community around a person and aren't really able to be controlled. A child involved in DFACs or having a criminal justice history is highly at risk. Having high populations of people who come in and out of the community, like military bases and cities with sporting events, major sporting events, street culture, a pre-existing sex market in the community raises the risk factor for children to be trafficked and sexually abused as well. Social risk factors are things in our society that put children at greater risk for exploitation, sexism, homophobia, sexualization of our culture, and increased use of technology. Now, an important thing to remember, and you'll see here along the side, drug and alcohol abuse and poverty can increase risk factors in all three of the categories. So that is the common thread that runs all the way through. So a big question I often get is, why don't these kids seek help? Why don't these adults or young adults seek help? And, there are a lot of factors. Some are obvious. You think of threats and fear. Shame is a big one. The shame makes them feel like no one is going to believe them, no one's going to listen to them. Many victims have some level of dependency on their trafficker. They're getting their needs met. They're getting shelter. They're getting food. They're getting clothing. They're getting a feeling of belonging. Sometimes they will see their trafficker as a boyfriend or someone that is taking care of them. Oftentimes, traffickers will get their victims addicted to substances or drugs, and that is where they get their next fix, is from their traffickers. Traffickers also often accompany their victims or send someone to watch everywhere they go, so a victim doesn't have a chance to ask for help. And I would note this, I know a lot of our folks joining us today are in the medical profession. This is a red flag to look for in a medical exam. Is there a person with this victim, is there a person with this patient that you are seeing who is speaking for them, will not let them speak for them? Is there a weird vibe between the two? If something has your spidey senses going, listen to your spidey senses, because we know that the majority of trafficking victims that we've talked to see a medical professional at some point during their trafficking experience. So being on the lookout, taking the time, if you feel kind of weird about the relationship between, two people in your exam room, see if you can get them separated and talk to your patient alone. And that will give them an opportunity to ask you for help. Now, that doesn't mean they're being trafficked, but it gives them an opportunity to discuss with you the fact that they're being trafficked and ask you for help. Victims often distrust law enforcement and other systems. A lot of kids have been in DFACS. A lot of them have been involved in the juvenile justice system, and they just don't trust law enforcement to speak out. And one of the things you don't think of, is particularly really young victims, is, their barriers because of their age. They don't have a driver's license, or if they have a driver's license and ID, their trafficker is holding on to it. They have a harder time accessing services. They don't know necessarily how to look for services and how to find services, but so they have a hard time getting services and getting the help that they need. So one of our top 3 questions was, who's likely to encounter a trafficking victim in your community? And this is just a list that I just sat down and just off the top of my head thought about. Your community may look different. There may be specific people that you think of while you're thinking about this that would encounter victims. So obvious ones: law enforcement, educators, medical personnel, but also youth group leaders, churches, scouts, softball coaches, community members, those kind of people. So think about who's most going to be able to spot these persons. So what training's available? We've got a lot of training in the state. We've got more training in the state now than we used to have. I serve on the statewide Human Trafficking Task Force. I'm the chair of the Community Awareness and Education work group, and we have trainings available. We do a quarterly Conversations with an Expert, where we bring in different experts from law enforcement, from different victim services agencies, and do kind of a deep dive into a narrow topic. It's a lunch and learn type of thing. So we have those available online. Law enforcement, prosecutor training. Our sexual assault nurse examiners, our SANE nurses, have a training program. They're industry specific and youth-focused prevention training through the Technical Assistance Resource Guide, which we're going to talk about in much more detail in a little while. One of the things that started as a part of First Lady Marty Kemp's Grace Commission is they created a very good overview of the human trafficking issue in Georgia. That training is mandated for state of Georgia employees, but it is also available to the general public. You can access it. I put the QR code on here if you want to hit that. You can also access it through the Georgia Department of Administrative Services to watch the training. It's 30 minutes. It's a great overview of what the trafficking issue looks like in Georgia, and it's the training that we point everyone to who wants to learn specifically about trafficking in Georgia. And this is the way to access the Technical Assistance Resource Guide, which we're going to talk about in a little more detail in just a minute. It's a document that's a really good resource. It was designed pretty much for educators, but it's very valuable. It's got a lot of information on sexual abuse training, sexual assault prevention training, and also offers a list of courses that they have vetted that are good for training and for teaching about human trafficking. So why is prevention so important? Well, we know that exposures to adverse childhood experiences, or ACEs, lead to a lot of problems in adulthood. Things like depression, substance abuse, poor school performance, eating disorder, and poor interpersonal relationship. We know that 1 in 10 children will be sexually abused before they turn 18. And we've already talked about, we see in Georgia that 80 to 90%, closer to 90% of children who are commercially exploited were sexually abused in a non-commercial manner prior to being commercially exploited. So one of the big prevention things that we can do as citizens of this state and of our communities is to do what we can to prevent childhood sexual abuse. So a few years ago, Georgia passed the law, Senate Bill 401, which made revisions to sex ed and AIDS prevention. And it requires school systems to provide annual age-appropriate sexual abuse and assault awareness and prevention education in kindergarten through grade 9. They are required to provide professional learning. That includes participating in or presenting at in-service training on sexual abuse and assault awareness and prevention, and also in-service training programs on sexual abuse and assault awareness and prevention for professional personnel. This law helps us work with students young up through early high school on how to prevent sexual assault, sexual abuse, how to create healthy relationships. We're going to look in just a little while of what age-appropriate means, so that you can feel a little more comfortable with what kindergartners might be learning about sexual abuse prevention. But we're gonna talk about that in just a minute. So the Technical Assistance Resource Guide, we call it the TARG, was created to address and provide a resource for this law. It includes best practices, principles of prevention, resources for the classroom, all of those kinds of things. This particular document was created by the statewide Human Trafficking Task Force Work Group 1, and was developed to be the guiding document for this law. Specifically, the guide intends to help school professionals identify what sexual abuse and exploitation prevention curricula and activities will work best in their communities. Like we mentioned before, every community is different, every community has different vulnerabilities, and this guide helps to decide, okay, what's going to kind of work well in our community. So it's up to each school and child-serving organizations to assess their specific resources and needs and then decide on a program that works best for your particular population. So before you can implement prevention strategies, you need to determine the best practices for engaging in sexual violence prevention. And these are 5 elements to creating a best practice program for your communities. It needs to be collaborative. It needs to be between the schools, the school system leadership, PTA leadership, youth-serving organizations, allied community partners, your child advocacy centers in your area. All of those can be a part of the collaborative effort to create best practices for prevention. Prevention programs provide tools and resources to diminish risk factors and strengthen protective factors. So things like promoting healthy relationships and sexuality, individuals effectively respond to problematic behavior, help caregivers provide open and encouraging environments, and help schools to teach body safety, particularly in the younger groups. The programs need to be universal, school-based programs intended to prevent violent behavior. So that means not taking the students that we've talked about who have certain risk factors and only teaching them. We're talking about teaching the entire community. So first and foremost, one thing we want to talk about, comprehensive strategies for prevention, is it's the adult's responsibility to protect the children from sexual abuse and exploitation. As adults in our community, as leaders in youth organizations and other organizations, that job's ours. We are the ones who are responsible for protecting our children. So that means our communities, we need training for all adults who work with children and youth. That is essential. Youth-serving organizations should have appropriate screening, child protection policies to include a code of conduct and reporting practice. Many of our youth-serving organizations have taken this as part of what they want to do. My family is very involved with the Boy Scouts. The Boy Scouts have youth protection training that all leaders have to take. They have policies in place that include 2 deep leadership, which means you have 1 child and 2 adults. Always 2 adults. There's never a one-on-one child and a leader. It's always 2 adults. And my church uses one called Safe Sanctuaries that teaches people who work with children, people who work with youth, how to use the policies that the church has. Again, it's similar to the Boy Scouts, 2 deep, 2 adults, always. There's never a one-on-one child and adult, always 2 adults present. So it's very important, and this is a way that all of us can work in our communities to help prevent sexual assault and sexual abuse and exploitation, is to take these programs seriously. Take the training. Most organizations like the Boy Scouts and our church with Safe Sanctuaries require you to retake the training every year. And yes, it is 30, 45 minutes out of your day to take the training. Take it seriously. Take the policies of your organization seriously. Promote them among the rest of your organization, because we can reduce vulnerabilities to trafficking by preventing child sexual abuse. We see, we just talked about it, 90% of our trafficking victims were sexually abused as children. When we prevent that abuse from happening, then we take away one of those major vulnerabilities for our children. So these are some of the principles of prevention. These are the same principles that the CDC uses to evaluate preventive measures, and these are the elements that should be included in all effective prevention programs. They need to be comprehensive, theory-driven, evidence-based, positive relationship. You need to have outcome evaluation, well-trained staff, and above all, encourage parental involvement. So we talked a little bit ago about age-appropriate teaching examples, and one of the things that the recent law requires is that there be this sexual assault and violence prevention teaching that happens age-appropriate in grades kindergarten through 9. So these are some of the examples of what you would have in a program for different age groups. So for kindergarten through 2nd grade, proper names for all body parts. And this is extremely important that children in early preschool and up, as soon as they're old enough, they know the proper things to call their body parts. Otherwise, they don't have the language, they don't have the words to tell you if someone is behaving with them inappropriately because they don't know what to call their body parts. Grades 3 to 4 talk about setting and maintaining boundaries. That's very important. Nonviolent and nonverbal communication skills, we hit those right before middle school. Dynamics of healthy versus unhealthy relationships for grades 7 and 8. And clear and accurate information about the concept of consent for 9th through 12th grade. So those are just some examples of what would come in that curriculum that you would want to evaluate as you're looking to train your community. These are some of the child-focused programs that are highlighted. They're currently reevaluating, they're being reevaluated, they're being updated. We're constantly, the target's several years old now, so we're constantly trying to make sure that it is as updated and as valuable as it can possibly be to you guys. And so this is my contact information. So if you would like more information on training programs for your community, if you would like help finding some specific trainings for your workplace, the CJCC has some excellent training programs. I can put you in touch with the folks that are over those. Children's Healthcare of Atlanta has some excellent programs on child sex trafficking and human trafficking, specifically for medical professionals. So you'll want to hit their website, or you can email me and I can get you connected to the right people. I did want to note there are 2 different hotlines that are available. Georgia's hotline is 1-866-END-HTGA, and that line goes to a phone tree, and you can figure out whether you need child trafficking, help with child trafficking situation, adult trafficking situation, a labor trafficking situation. It's just a great resource for getting help if you suspect some trafficking in your area, in your community. And then there's a national hotline that is run by Polaris, and it's 1-888-373-7888. So those are the 2 main hotlines. If you need to call, and you need to call the hotline, call the Georgia hotline first. If you do call the national hotline, they're going to reroute you. They're going to listen to you, take your information, but then refer you to the Georgia authorities. So if you just go straight to 866-END-HTGA, you are there with the Georgia authorities right there at the beginning. So please feel free to contact me if I can be of any assistance in helping you guys. As the last presenter of the day and also a member of the Georgia Commission on Women, I get the opportunity to thank you all for attending. We appreciate you being here. We appreciate you taking your Saturday to spend time with us to learn about how to be healthier and how to help create a healthier Georgia in our communities. If you missed any of the presentations today, you can access the recording online at the website. The breakout sessions will be available on the website. You will receive an email soon with instructions on accessing CEUs and how to do that. I hope you guys have a fantastic weekend. Thanks again for joining the Georgia Commission on Women for our 2023 Georgia Wellness Summit. I want to just thank all the folks that have been involved in putting this together. Janessa Smith, come stand up here with me so they can look at you. Janessa is our executive director, and she herds all the cats. She keeps us all in line, and she tries. But she's the one who organized this fantastic event, and we just appreciate your help with that. And with that, thank you to Brian and the 444 group for taking Janessa's vision and turning it into a summit. Thank you to our presenters today. Thank you to our hosts, our MCs, and I guess I've thanked everybody. And I will sign off. Have a great weekend, and we hope to see you next year at the 2024 Georgia Wellness Summit. Bye, y'all.